Well, good morning, everybody. It's 10:02, and I'd like to officially call our meeting to order. Please note that this meeting is being recorded, and with the departure of our previous chair, Dr. Mark Galley, I'll be chairing today's meeting as the vice chair of the Healthcare Affordability Board. We do anticipate electing a chair at our next board meeting. So with that, I'll now ask for a roll call, please.
Good morning, Dr. David Carlisle. Dr. Sandra Hernandez.
Here.
Secretary Kim Johnson.
Here.
Richard Kroenig.
Here.
Ian Lewis.
Here.
Elizabeth Mitchell.
Here.
Dr. Richard Pan.
Here.
Don Molds. 6 present and 2 absent.
Great. With that, we will establish a quorum for the meeting. Before I give it over to the director, I do want to welcome Secretary Johnson on behalf of the board. We're looking forward to working with you. Thank you very much for your leadership. This is a board that's been very committed to the mission of OCA and making healthcare more affordable in the state. So welcome to you, Secretary Johnson. Okay, Director Landsberg, over to you.
Thank you very much. Good morning, everyone. So I'm going to start by reviewing our agenda for today. So after our executive updates from Vishal and myself and approving the minutes, we're going to move and take our informational item 5A out of turn. So we'll do all things primary care investment together. So we'll be talking, Margaretta Brandt will give the presentation on the proposed primary care definition and investment benchmark. Then we'll move up to 4A for the action item on primary care investment. And then we have 2 additional informational items. We have an update for the board about our cost and market impact review program, the transactions that we've had to date. So Sheila Tatayan will cover that. And then last, we have our OCA statutory authority to address high costs. This is a continuation from the discussion that we had at the Monterey board meeting, and I'll talk a little bit more about our follow-up items as will Deputy Director Vishal Pagani. So moving on to executive updates, I want to note that OCA is providing simultaneous Spanish interpretation during this meeting for any members of the public who would like to access that. We have headsets in the back here, so if you'd like to access the Spanish interpretation, please take a headset from the table and return it when you're finished. If you need interpretation in another language, please request that ahead of time, and we're happy to provide interpretation services in other languages, as well as noted on our agenda. Today being Indigenous Peoples Day, we have included HCI's land acknowledgement statement this morning. So our land acknowledgement statement was developed by HCI's racial equity team. So HCI Sacramento and Los Angeles offices sit on land stolen from the Miwok, Nisenan, Chumash, and Gabrielino Tongva peoples. We acknowledge the resilience and fortitude of the Miwok, Nisenan, Chumash, Gabrielino Tongva peoples and other Native peoples who, despite efforts at genocide, survive as cultures and communities today. So I'm not going to read the whole land acknowledgement statement, which is provided here, but we do acknowledge the cross-generational trauma, the systemic racism, and the historic discrimination that have occurred against Native American peoples, which was perpetuated both by governmental entities and private entities, and we feel it's an obligation as a governmental entity to take specific steps to remedy that to the extent we can at this point. So I'm proud to work for a governor and a secretary who take this very seriously. Secretary Johnson's been a leader in terms of interactions with our tribal communities. Here at HCI, we focus very much in our outreach and stakeholder engagement efforts at making sure that we're connecting with tribal communities. I was actually just looking at a report last week on our wellness coach profession, and it was one where it was great to see that we actually had overrepresentation from the Native American population as we build that profession. And so we're very mindful as we work on our data programs and all of our equity programs to lift up these communities. So we're endeavoring to promote racial and health equity throughout our workplace and with our many programs. And today is an important reminder of both progress made and many challenges that remain. Moving on my executive updates, first I would like to acknowledge Secretary Mark Galley and his recent departure as the Secretary of Health and Human Services and as a member of this board. So I think most folks know that Dr. Galley's last day as our secretary was September 31st. He's certainly been an incredible advocate for this Office of Healthcare Affordability. When he hired me about 4 years ago, he said, we're gonna get this office done. Was really pleased to work with Vishal and Secretary Galley and Senator Pan and Assemblymember Wood, many stakeholders who are here today. It took a couple of years to get that statutory language just right, but we did, and so it's been wonderful to see Secretary Galley's commitment. I know it was really important to him to make sure that we did the Monterey board meeting while he was still here. So he has led Cal HHS since March of 2019. Obviously, when he came in, he did not know, as none of us did, that we would have the pandemic. Secretary Johnson convened the HHS directors to do a tribute to Dr. Galley, and there were a lot of meaningful reflections about the really first and the really nation-leading nature of the pandemic response that she and he and many others participated in. So I certainly won't go through all of Dr. Galley's accomplishments, but they are certainly many with the Medi-Cal program, with CalAIM, from birth to the end of life. You know, he created the master plan for aging, the Children and Youth Behavioral Health Initiative, a lot on the behavioral health side, foster care side, so launching CalRx. So we wish him best in his future endeavors and know that he will change lives for the better wherever he may serve. And we are very thrilled that, that the governor chose to appoint Kim Johnson as the new Secretary of the Health and Human Services Agency, and wonderful to have her as a member of our Healthcare Affordability Board. She and I did the oath of office before, and she is officially a member of this Healthcare Affordability Board. So I've had the pleasure to get to know Secretary Johnson and work alongside her. Prior to her appointment as agency secretary, which she started October 1st, so 2 weeks ago, she has served since 2019 as the director of the Department of Social Services, where she led a team of over 5,500 employees, serving millions of Californians with our safety net programs, CalWorks and CalFresh and the foster care system and assistance for immigrants and many, many, many other programs. So she has a deep and abiding commitment to equity, to our safety net, to affordability, and to access to all Californians. So thrilled to serve under her leadership and so glad to have you here, Secretary Johnson, and want to give you the opportunity to introduce yourself.
Thank you so much, Director Landsberg, and it's a pleasure to join you all in this phenomenal effort with just key objectives here related to healthcare affordability. I'm very much looking forward to being part of this board, and I want to thank both Dr. Galley and Director Landsberg and the team for onboarding me and ensuring that I was up to speed on the phenomenal work of this board, but also what we have ahead of us both today and in the future, and really looking at, again, reaching our objectives. I obviously have spent a career focused on access, affordability, quality issues in a realm of space, mostly in the space of disrupting poverty. So health is not new in that space, obviously a huge component of the work that we're doing, but obviously, as you've heard, primarily focused on the human services space. So very much looking at how that is applicable in the healthcare space, but also learning more and leaning into really understanding the levers that we can continue to pull in opportunities that we have and making healthcare more affordable across California. So thank you to community. I know this group has been out in community, which is also near and dear to me, again, with an equity focus. That's a huge piece, as well as being informed by data in the work and evidence in the work that we're doing. So very much look forward to working with this board and engaging with community on achieving our goals. Glad to be here.
Thank you very much, Secretary Johnson. There are a whole bunch of talking points I didn't hit about her over 25 years of experience working in community-based organizations and government, but we're so thrilled to have you here on the board. Let's see, moving on to legislation. So October is here, and so that means that legislation has been acted upon, and I was going to mention a few bills that relate to HCI and then a few that relate to OCA. So there are a couple of bills related to medical debt, charity, and discount care, and we know that medical debt continues to be a significant issue for many Californians. So AB 2297 is a follow-up, one of several follow-ups to the hospital fair billing law by Assemblymember Friedman. So it expands protections to patients who need financial assistance for hospital bills. So the changes will improve access to hospital financial assistance programs by prohibiting eligibility time limits, clarifying what can be included in a patient's cost to be waived or reduced, and prohibiting liens on real property, including homes, which is very important as a means to collect unpaid hospital debts. In addition, I want to call out Senate Bill 1061, which prohibits reporting medical debt to credit reporting agencies and prohibits these agencies from including medical debt on their reports. Again, a very significant change. There are moving on to seismic safety standards for hospitals. There are two bills that were signed that allow hospitals to apply for extensions of the current 2030 seismic safety deadline. And that 2030 deadline requires hospitals to be capable of providing care after a major earthquake. SPC2 buildings, for those in the know. So Senate Bill 1447 impacts Children's Hospital Los Angeles, and then AB 869 by Assemblymember Wood impacts small, rural, critical access, and district hospital, as well as those hospitals that received loans under the Distressed Hospital Loan Program. And so any of those hospitals can seek approval from HCI for a delay if they submit an approved compliance plan with milestones. So it's not just a free ride, but if there's a compliance plan where we see that they'll be able to reach compliance, they can apply for an extension. Governor Newsom vetoed two bills in the space. One bill, Senate Bill 1432, which would have given broad extensions to all hospitals to delay the 2030 deadline for 5 years. That bill was delayed, and a bill extending the 2025 deadline to no longer being a collapse hazard for a particular hospital system. So those bills were both vetoed. The governor also vetoed Assembly Bill 3129, which would have required private equity groups and hedge funds to obtain Attorney General approval prior to acquisitions or changes of control of certain healthcare facilities and provider groups. In his message, the governor noted that OCA was established to review mergers, acquisitions, and corporate affiliations involving healthcare entities and to analyze healthcare consolidation. The message also acknowledges that HCI can refer transactions to the Attorney General, and we appreciate the technical assistance and the collaboration we've had with the Attorney General's office. The governor also vetoed Senate Bill 966 dealing with PBMs or pharmacy benefit managers. So this bill would have required PBMs to be licensed by the Department of Insurance. Today, PBMs have to register with the Department of Managed Healthcare, and moving forward, HCI and DMHC are reviewing approaches to collect information on PBMs. So I think there's an acknowledgement that more needs to be done in this area. Next, I want to provide an update on some of the work that came out of our board meeting in Monterey County last month. And I just want to start again by thanking the staff for all the work that went into putting that meeting together, and all of the board members for coming. I think it was really important for all of us, as Secretary Johnson noted, to be in community and appreciate the community, inviting us and the broad participation in that meeting. So in terms of some follow-up items, as part of OCA's charge in analyzing the healthcare market, we can conduct studies on the healthcare market, such as the impact of consolidation, market power, and market failures on competition, prices, access, equity, and quality. These studies can include research and investigation, and this slide has some of the citations to that authority under the statute. So I want to let the board and the public know that I have directed our OCA staff to commence an investigative study of hospital market competition in Monterey County. So the focus of the investigative study is to assess market competition, consolidation, presence of a market failure, and any anti-competitive effects on cost, access, and affordability for healthcare services in the region. OCA may refer its detailed findings to the Attorney General, who may take further action. And we will complete the investigative study working with economic experts and will publish a report of its findings. So, you know, at the August Monterey Board meeting, we presented the publicly available data that we have, and this investigative study will take it to the next step. Due to the investigative nature of the study, OCA will provide status updates, but will not disclose specific information about the study until the report is published. Secondarily, in terms of follow-up from the Monterey Board meeting, I was very concerned that we heard from a number of members of the public who testified about very aggressive practices in seeking payment from patients who are still undergoing treatment before they were even discharged. So I'm concerned these practices, at the least, are insensitive and may well violate the law in terms of billing and collection practices. So we'll be seeking additional details about these practices to see if a legal line was passed. And then moving on, you know, I want to acknowledge that several people testified at the Monterey Board meeting asking the board to adopt a sector target on high-cost hospital outliers, high-cost outlier hospitals. So at the meeting toward the end, we laid out the steps involved in adopting sector targets and some of those considerations. But frankly, we didn't have enough time for robust discussion about that topic. It was really important for us to hear from people who had taken the time to be in the room. So we've included those slides again in this meeting and want to get input from the board on your interest in potentially adopting a sector target before 2027 and hear your feedback about what parameters you'd like us to explore in potential sector targets. I do want to temper expectations. Our team has an awful lot on their plate with the many work streams that we have in progress. And we still need to socialize with the board and the public the work that's been done and the initial approach OCA has developed for measuring hospital spending. But that said, it'll be really important to us to hear from you all today as we consider the feasibility of adopting sector targets. So more on that at the end of the meeting. Okay, just a couple of high-level HCI updates. And let's see, for HCI's workforce development programs, I wanted to note that we've recently launched a behavioral health transformation webpage accessible through our HCI website under workforce initiatives. Behavioral health transformation is the effort that will implement the Proposition 1 ballot initiative and the Behavioral Health Services Act. So under the Behavioral Health Services Act, 3% of the funding will come to HCI for behavioral health workforce development. And my workforce team has engaged in a very intensive process to build out a supply and demand model for behavioral health workforce and nursing workforce, and to develop a strategic plan for behavioral health workforce. So more to come on that. We are working alongside our sibling department, Department of Healthcare Services, to negotiate. They are negotiating a waiver for behavioral health workforce that we hope will be able to draw down significant additional federal dollars to help build out the behavioral health workforce that is very much needed in California. And my last update deals with HPD, or the Healthcare Payments Data Program. So our HPD staff are currently reviewing the public comments provided for the HPD non-claims payment data collection regulations. So our OCA team and our HPD teams work together to develop a framework for non-claims payment, and we will start collecting non-claims data in the HPD. And at the HPD Advisory Committee meeting next Thursday, staff will share progress and solicit input on our public reporting priorities and share the most recent data reports. I want to note Dr. Pan had asked at our last meeting for an update on the HPD, and so we will be scheduling that for an upcoming board meeting, so you all can see. We'll do a deeper dive on the HPD and the data that's available. And with that, I will turn it over to Deputy Director Pagani.
Thank you, Director Landsberg. First, I want to provide an update on total healthcare expenditures, or THCE, data collection efforts. I want to let the board and the public know that in August, OCA received aggregate Medicare fee-for-service expenditure enrollment data from CMS for calendar years 2022 and 2023. So this is for the purpose of our baseline report that's required by statute. And in addition to the existing data we collected from CMS, there was also a TME, or total medical expense, data submission deadline for non-managed care organization plans. So these are the non-Medicaid managed care plans, so commercial and Medicare Advantage. The data was due for those types of plans September 1st. And it covered calendar years 2022 and 2023 data. And then as of October 8th, OCA has received complete submissions from 15 submitters, and 2 other submitters have submissions in progress. For the TME data we've received to date, we're currently carrying out data quality assessments, and we're beginning to schedule another round of one-on-one meetings with the payers to review their submissions. In late February 2025, OCA expects to receive total medical expenditure files from DHCE on the managed care plans. So these are all kind of separate work streams for the different markets are all working towards gathering the data, validating it, and analyzing it for the June 2025 baseline report. Next, I'd like to highlight an interesting article published on the Health Affairs website in August, which analyzed spending data from Connecticut, Delaware, Massachusetts, Oregon, and Rhode Island. It was found that in states with spending targets, spending growth moderated in 2022 compared to 2021, but still exceeded their respective targets. For 2022, these states set their spending targets between 3 and 3.4%. Rhode Island was the only state to meet its spending target of 3.2%. It had the lowest rate of spending growth at 1.6%. Oregon's 2022 spending grew 3.6%, only slightly exceeding its 3.4% target. Connecticut also slightly exceeded its 3.2% target with spending growth at 3.4%. Meanwhile, Delaware and Massachusetts significantly exceeded their targets with 22 spending growth of 6.3% and 5.8% respectively. The next slide depicts statewide spending growth in 2021 and 2022. Even though most states did not meet their target, spending growth was much lower in 2022 compared to 2021. Delaware's 2021 spending growth was highest at 11.2%, followed by Massachusetts at 9%. This growth has since moderated, and spending increases in 2022 largely mirrored pre-pandemic levels. While continuing to exceed targets, and then while Delaware and Massachusetts continue to have the highest spending increases, their 2022 spending growth was much lower than 2021 at 6.3% and 5.8% respectively. So on the next slide, I'll cover some of the more granular aspects of what was driving spending. The authors of this Health Affairs article noted that retail prescription drug spending was generally the fastest growing spending category across states. In 2022, hospital inpatient spending dropped in 4 states and remained flat in 1. The authors suggested that that the 2022 slowdown in spending isn't likely to be long-lasting due to the significant reimbursement increases that healthcare providers sought in their contract negotiations with health insurers following the period of high inflation in late 2021 through 2022. So this likely will play out in the form of high spending growth in both 2023 and 2024. Now that these states have collected and analyzed several years of data to understand the drivers of healthcare spending and spending growth, the authors note that the focus must turn to implementing policies that address high and rising spending in order to make healthcare more affordable. So OCA looks forward to contributing its data to this collection of states. We will soon be publishing our 2022 and 23 data in the spring. So that'll give more additional data points and to comparing state by state performance. Next, I'd like to let the board and public know about the 2025 Board and Advisory Committee meeting dates as shown here on the screen. So these dates are also available on HCI's public meeting website. And lastly, as we do at every meeting, I'd like to remind the board and the public about our slide formatting. So the OCA statute denotes different roles for the board in different areas. We use a yellow area in the presentation for areas for which OCA has decision-making authority. It's important for OCA to use the format of public meetings to get stakeholder input, and these meetings are an important way to engage both the board and members of the public. For areas where there's a green arrow, that signifies that the board has ultimate decision-making authority. So I'll now turn it back over to Chair Hernandez to facilitate discussion.
Thank you. Let me thank you, Director Landsberg, Michelle, for those updates. Let me open it up to the board for questions, comments. Ian, we'll go right down the line. Please.
Obviously, I'm thrilled that we're launching into this investigation in Monterey, and it's a big step, and I really appreciate the director and the staff kicking that off, and also being so responsive on hearing some of the particular feedback on billing practices. That's exactly how this board should operate, and I really appreciate that. Can you give us understanding that things will change as the investigation progresses and we get information or we don't? Do you have any sense of how long the horizon is before we get to a report we can hand off to the Attorney General?
Sure. Excuse me. We have a preliminary approach, and we have a preliminary time frame, but much of that time frame is going to be dependent on the cooperation of the people that we want to speak to or the people who we will ask to provide documents. So we don't really have a sense of exactly how long that will take, but at the outside end, I would say optimistically, if all goes well, 6 to 9 months.
Thank you. And again, understanding this is an investigation, you have to be careful legally. I hope if there is any resistance to sharing to full transparency, given the mandate of this board, that you can share that with us and with the public. So thank you.
Dr. Pan.
Thank you. Well, first of all, again, I appreciate the presentations. I too want to just briefly thank Secretary Ghali, who I had the opportunity to work with as not only chair of the Senate Committee on Health, but also the budget sub-chair on Health and Human Services. So, of course, I have to interact with the entire agency, not just with the health folks as well. And, we worked on vaccinations together when I first started out. We talked about that. And, of course, this body, creation of this body and so forth. I also want to welcome Kim Johnson as well, who I got to work with as well as in the legislature. And I want to thank you so very much for your implementation of the API equity budget, which your agency took the lead. I guess your former agency, although it's still under you, Social Services. So thank you. And also the many accomplishments that you've had in your leadership of the Department of Social Services. I was proud to be able to hopefully been a good partner on the legislative side for that work as well. So thank you. Thank you, Ian, for that question. I was going to ask that question about the investigation timeline, but the other question I also had on the health affairs piece, one of the things that I would just make note, I mean, we talk about states, right? But the states, when you start thinking about where they're geographically located and where they're in their size, so I just make note that Rhode Island, Massachusetts, and Connecticut are all adjacent to each other, right? They, in fact, actually, and if you put them all together, they're smaller in California, and yet you see such a variation. Now, of course, they have different state governments, but you see a tremendous variation between the three, right, in those results. And I'm just thinking what sort of lessons that has for us as we're looking at our own data. So essentially taking a geography that's smaller than all of California in there. And so as we're, collecting the data and, we're going to present certainly statewide data. And this also speaks to a little bit about our future discussion on sector targets. Geographic breakdown might be particularly insightful, right? Now, I'm not saying that all the variation we're seeing between these two states is due to geography or maybe even separate healthcare markets, but, our state has tremendous variety, and I think that as we're looking at the data, if we just look at across the whole state and sort of just say, well, everything's the same across the whole state, I think we're going to miss a lot of stuff. And the state is diverse and as large as ours, both economically as well as in many other characteristics. So, we did talk about those covered California regions. But I think that having some sort of breakdown by region is going to be really important for us to better understand. But I am curious, and you probably don't have the answer right now, but I mean, the fact that those three states were right adjacent to each other have such different results, what does that mean exactly? They're right next to each other. They have some overlapping healthcare markets. Obviously, again, different state governments, so perhaps different policy differences. But I think that's something to really ponder about as we look at the data that we're going to look at for California. Thank you.
Yeah, thank you, Dr. Pan. So for the data collection that OCA is undergoing right now, we have collected regional total medical expense file, so it's by those covered California rating regions. So we'll be able to look at that variation and kind of, we typically hear about the north and south divide, but we'll be able to go into more granular types of analysis. And then some of the differences between those three states, Rhode Island is different from the other two, and they have like an existing hospital price growth cap or rate, like a cap on the rate of growth. So some of their spending is moderated is likely moderated for that reason. And then the other states, there are some kind of differences in kind of the coming out of the pandemic and then people going back to care, and then they also noted in their reports kind of the specialty drugs, but we'll continue to kind of look at that variation. But yeah, California is a huge state, and we hope to have a tailored approach.
Elizabeth?
Thank you. I had a similar question about the timeline of the Monterey investigation, but I also noted that some of the hospitals made an announcement that week that they would be taking steps to lower their costs. Could we, as a board, get copies of their plan, that whatever they announced? Do we have any detail on what they are proposing?
CHOMP, the Community Hospital in Monterey Peninsula, did submit a letter to the board that I think outlined some of their steps. So we do have that in your board packet. And I don't know if we have the paper on the other announcements or not.
We don't. They did identify some, I believe it was 50 million in cost savings initiatives. And then they said they would follow up with more details on kind of the specifics later.
That's what I was referring to.
Yeah.
Can we get those specifics?
We could look into that. Yeah.
Okay, that would be great. And then also, on the veto, we wanted to really thank Assemblymember Wood for moving the anti-consolidation bill forward, and we're disappointed in the outcome. But I guess you had mentioned that we are already sort of stretched thin in terms of capacity. Is that Noting that that work will now also come to OCA staff, is that going to be a challenge? Do we have the capacity to address those issues?
I mean, we have a wonderful team that's working hard. I mean, all three of our assistant deputy directors are continuing to fill out their team, and we hope to be able to handle the work. It will certainly come back to if we're not able to do so. But at this point, we certainly are. I don't know if there's anything Vishal wants to add.
Yeah, we're staffed to look at those transactions. I think the comment about being stretched thin, it was more about kind of adding new work streams. But the looking at our regulations would capture transactions that involve private equity. So that's part of our existing workload.
Rick, did you want to get in?
Just really briefly to second Ian's comment that I'm delighted that the office will be initiating a study or investigations of Monterey, and I look forward to the conversation later today about the sector-specific targets, which I think is really important to try to move on as quickly as possible, consistent with the many demands on the office.
Secretary, anything like that? Well, let me just really appreciate your leadership. I think the Monterey hearing was extraordinary, and I think on behalf of the board, we're anxious to hear what a deeper dive into the data will show there. So thank you for that. And yeah, I think the data from Health Affairs, Vishal, would be interesting to do a deeper dive with the folks from Massachusetts to really understand what's happening in particular with the dramatic rate and spend that they're experienced in 2022 beyond what's in the actual Health Affairs article. So I think as much as we can learn from other states, we should continue to try to do that. So I would encourage us to contact them and really try to dig into their data and understand what's driving those costs.
Yeah, thank you. Yeah, we did invite the three states early on to speak to the board, so we could take that back in terms of that was over a year ago, so kind of having another conversation with them.
That'd be great. Okay, if there's nothing else from the board, I think we will take public comment on the reports from Director Landsberg.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to public comment, we will alternate between members of the public in the room and those attending virtually. Those in the room can line up at the podium. Those attending virtually can raise your hand. Those dialing in can press *5 to raise your hand. It will track the order in which the hands were raised. During public comment period, you will be unmuted when it's your turn. We also invite you to provide written comments at oca@hchi.ca.gov. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that's not also included on the meeting agenda for today, except to place the matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Beth Capel for Health Access California. I want to join the board in commending the staff for the meeting in Monterey. That was really an extraordinary overview that was assembled of those hospitals and their impact on affordability in that community. And also to commend the many community members who came out to protest the reality that Monterey has some of the highest hospital costs in the United States, which is really quite extraordinary. And to encourage the investigative study to move promptly so that we may move to a prompt discussion of sector targets for those very high cost outliers in the Monterey area. And we'll come back later today to talk more about sector targets, since we've written to you 3 times about them, so they're obviously on our mind. Thank you.
Thank you. Looking to virtual attendees. Seeing no hands raised at this time, going back to the individual at the podium.
Janice Rocco on behalf of the California Medical Association. Welcome to the new secretary. And we appreciated the meeting in Monterey. Those of us who couldn't attend, given the legislative session, were still able to watch it. And it sounds like we've already had some positive outcomes from that. So congratulations. In terms of AB 3129, I did want to say that with the veto of the legislation, the Attorney General can get a referral from OCA, but doesn't have the authority to prevent the transaction. He or she would have to litigate, which is resource intensive and would likely take place after the transaction has already completed. CMA had asked OCA not to move forward with the amendments to the CMIR regs that added in private equity until we knew the outcome of that bill, so that there wouldn't be the potential of overlapping authority. And the veto tells me that we were correct in asking for that to occur.
Thank you. Looking back online, seeing no hands raised, going to the podium.
Hi, Ivana Krajcinovic with Unite Here Health. We were really heartened to see this slide in the discussion on sector targets later today, to know that the board didn't view the Monterey hearing as one and done, but that you're going to continue to look at it. We really welcome the further investigation into hospital pricing in Monterey. Part of me feels like, okay, there's enough data, but then I think as we peel back the layers of the onion, there's more to look at. We really encourage you to take a look at spending on things like chemotherapy and specialty medications. There's a lot of talk about how drug prices are driving up costs, but very little talk about the high margins that places like hospitals are putting on these drugs. Our medical director testified to this in Monterey, but it's pretty shocking to see chemotherapy being marked up to like 800 or even 1600% of Medicare, because this is pure markup. This is not something that the hospital is developing or putting back into research and development. And that's Medicare, and we know that these hospitals get 340B pricing, so the margin is even bigger. So we really hope that you can drill down and look more into those costs. I was really happy to hear about Elizabeth Mitchell's question about the $50 million that CHOMP has pledged. I think it's important to also put this in context. It's a significant amount of money, and we recognize that. But when you think about it, it's $50 million over 2 years, $25 million per year. They have $1 billion in reserves, so that's a 2.5% return on that. I think they probably do better than that. If you also look at their net operating revenue in 2022, the last year that we have audited results, they made $86 million in net operating revenue, so 86 million compared to 25 million, and they were at a percentage at 10.67%, where the statewide average was under 1%. So they could basically double this amount and still be making more than the statewide average. So
2 minutes.
We hope that you can take that into account as well as you explore this further. Thank you.
Thank you. Looking virtually, Steve Shortell, I see your hand raised. You are unmuted on our end. Please go ahead. Steve, you should be unmuted on our end, but we can't hear you yet. You might need to unmute on your end. Steve, if you look in the upper right-hand corner of the screen, you should go ahead. I think I can hear you.
Can you hear me now?
I can. Please go ahead.
Okay, yes. Berkeley School of Public Health, also a member of the advisory committee. I just want to underscore the importance that I think Senator Pan mentioned earlier of the granularity of the data broken out by regions and so forth. But when you do so, to the extent you can, to also within the counties and regions, show the supply side in terms of the availability of physicians, nurses, and so forth, and also the practice models that are in those regions. And to the extent you can and data are available, the extent to which land 3 and 4 payment models are being used, they are part of accountable care organizations, whether any direct contracting is going on for primary care, which relates to the investment in primary care, later discussion today. So those kinds of data are immediately available to try to understand the granular regional and county variation. Thank you.
Thank you. Looking back in the room, seeing no one lined up at the podium, seeing no hands raised virtually, that concludes public comment on this item.
Great, thank you very much. Let's move on to consent items. Deputy Director Pagani?
We just have the August meeting minutes. The minutes have been distributed and include written public comments we've received since the August meeting.
I'll entertain a motion to approve.
So moved.
Is there a second?
Second.
Any comments on the minutes? Any public comments on the minutes?
We'll now take public comment on this agenda item. Please line up at the podium. If you're attending virtually, please raise your hand. I'll give it a moment. Seeing no public comment at this time, that concludes public comment.
Great, let's take a vote. Do a roll call, please.
Dr. David Carlisle. Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson.
Abstain.
Richard Kroenig.
Approve.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye.
5 ayes, 1 absent, 1 abstain.
Great, I think the minutes are approved. So unless there's anything else from the board, let's turn it over to Margarita.
Good morning, members of the board. Margareta Brandt, Assistant Deputy Director for Health System Performance. Today I'll be providing an update on our proposed primary care definition and investment benchmark. Also joining me today is Mary Jo Condon from Friedman Healthcare, who can assist with answering questions. So during this portion of the meeting, we will continue our discussion of OCA's approach to the primary care definition and investment benchmark. We appreciate all the feedback we received in June, and we are providing a few updates today based on that feedback. So these are our 2 follow-up items for today, and then we can go to the next slide. So just as a brief reminder, this is our statutory language that guides our primary care work. It requires OCA to measure the % of total healthcare spending allocated to primary care and set spending benchmarks for primary care that recognize historic underfunding of primary care services. It also notes that measuring primary care spending must consider categories of providers, procedure codes, and claims and non-claims payments. And it directs OCA to drive the healthcare system to reallocate resources from specialty care to investments in primary care and behavioral health services. The statute focuses on improving outcomes for primary care, so it identifies strategies such as increasing the use of advanced primary care models, integration of primary care and behavioral health, and the adoption of alternative payment models to support primary care. So these are the policy goals that we've kept in mind as we developed the proposed definition and the recommended investment benchmark. And on the next slide, we've been meeting with the investment and payment work group monthly for more than a year to provide us input on our primary care work, our behavioral health work, and also our alternative payment model adoption work streams. These are the members of the work group, and work group members have provided input as we developed and iterated on proposals for the definition and the benchmark over 10 months. We've considered a variety of perspectives in our work group discussions, and in some cases, work group members collaborated across the group to develop alternative proposals, many of which we've adopted. And the members highlighted in light blue here have recently joined the work group as we transition to focus on developing definitions for behavioral health and setting a behavioral health investment benchmark. And then our next slide, we'll share again the vision that the work group has used to guide its work. So this is a vision based on one developed by the California Quality Collaborative for primary care delivery in California. And the work group in its discussions adopted this vision and emphasized that sustainable, well-resourced primary care is needed to meet this vision. So we use this vision along with OCA statute as guideposts for developing the primary care definition in coordination with the work group. So on our next slide, First, we'll discuss our proposed primary care spending definition and methodology, and we can move to the next slide. So this is a brief summary, and then we'll walk through these revisions in more detail. So based on the feedback we received in the June meeting from the board members and from public comment, we've updated our primary care measurement definition and the claims-based code set to capture several additional provider, service, and place of service codes. And these codes align with OCA's approach to the definition, but had not been included previously. So as noted on this slide, family medicine and adult medicine taxonomy code for providers and digital evaluation and management service codes have been officially discontinued, but we've added them based on feedback during the public comment process that they are still used. So we've added those. And then place of service codes have been updated to include additional care settings based on feedback received during prior board meetings and in coordination with DHCS, the Department of Healthcare Services, on our primary care definition. Also, service code definitions include additional codes for behavioral health integration and several new CMS codes for chronic care management and advanced primary care management. So on the next slide, we'll go into detail about our proposed methodology. So as a reminder, when we measure primary care spending, we're measuring the dollars that payers send to providers or provider organizations in support of primary care services. And payers are submitting the primary care spending data to OCA currently. And so payers may not know exactly how much money providers or provider organizations are spending on primary care and how exactly they're distributing those dollars, but based on our definition, we believe we're getting to a good estimate of primary care spending across the healthcare system. And on our next slide, we provide an overview of our claims-based spending definition, and then we'll go into more detail about each of these. So again, OCA plans to include claims-based spending when a primary care provider performs a primary care service in a primary care setting. So all three of those components must be met for the spending to count towards the investment benchmark. So for providers, OCA plans to include a broad set of providers to reflect the statutory goal of promoting team-based care. And the one note here that we'll talk a bit more about in coming slides is that the investment and payment work group, the advisory committee, sibling departments, and many stakeholders have discussed at length whether to include OBGYNs in this set of providers. And OCA is recommending excluding them at this time to align with the vision of coordinated comprehensive primary care. However, and we did receive feedback strongly recommending including OBGYN providers. However, the predominant feedback from stakeholders, including public comment, supported excluding those providers. For setting or place of services, we exclude certain care settings such as inpatient and retail clinics, again to reflect the work group's vision of promoting continuous coordinated primary care. And for services, we include an expanded set of services to encourage as much primary care as possible and appropriate to be delivered in a primary care setting. So this includes a limited set of behavioral health services when provided by a primary care provider in a primary care place of service. And on the next slide, we share again our kind of flow chart of identifying claims-based primary care spend and the additional nuance that we worked with the work group and the Department of Managed Healthcare and other sibling departments to develop to add nuance to our definition of primary care spending. So using this flow chart, payers are asked to identify claims with a primary care provider taxonomy as defined by OCA. And if the primary care provider taxonomy is a physician, nurse practitioner, or physician assistant, then the payer confirms that the provider is identified as a PCP in the DMHC annual network report submission. And so this helps us provide more specific spending estimates. For example, an internal medicine physician who is not identified as a PCP in the payer's annual network report would be removed at this step. And then if the provider is identified as a PCP, they continue down the stream to confirm that the service was provided in a primary care place of service and the service is in our definition. So on the next slide, we'll share again our list of primary care provider taxonomies. So these are the proposed primary care providers included in our definition. And of note here, to support the concept of care teams, providers such as nurses and pharmacists are included in the definition, even though they are less likely to be the source of claims-based billing. And the provider taxonomies in green text were added after the June 2024 board meeting to reflect board and public comments. So those were community health worker and critical access hospital clinics and centers. And so just want to reiterate here again that taxonomies do not always reflect a provider's current practice. So this is why we're using the primary care provider designation with the DMHC and complementing the provider taxonomy with the place of service and the service itself. So moving on to the next slide. So as we've discussed before, OCA's proposed definition for primary care excludes OBGYN providers as primary care providers. And therefore, it also excludes the services that OBGYNs provide. The definition does, however, include a limited set of women's health services when delivered by a primary care provider. And as I noted earlier, some stakeholders have commented that OBGYNs typically do not provide coordinated comprehensive care for all body systems and therefore should be excluded as primary care providers. However, others have said that OBGYNs do provide this comprehensive care and have expressed concerns about the discordance between statutory guarantees of access to OBGYNs and OCA's primary care definition, as well as the inconsistency of including reproductive health-related services when provided by other primary care providers. Ultimately, OCA does not have data currently to assess whether OBGYNs typically provide comprehensive coordinated care for all body systems. OCA did consider developing a separate primary care provider definition with a more limited set of services for OBGYNs, but determined that this would be burdensome for data submitters, especially for separating out non-claims payments. And we want to stress that OCA's primary care spending definition does not in any way change a consumer's right to choose an OBGYN as their primary care providers, and that OCA will use the Healthcare Payments Database, or HPD, to understand the proportion of OBGYNs who provide primary care consistent with the vision for coordinated, comprehensive integrated care. And based on these findings from the HPD analysis, we will revisit our decision whether to include or exclude OBGYNs in the definition. And so we're looking forward to launching that work, and we'll come back to the board based on that analysis. So next we'll move on to services included as primary care. So again, OCA includes a broad set of services, many in our primary care definition, to promote comprehensive primary care and primary care providers working at the top of their license. And many of these were added and identified by DHCS for targeted rate increases. And so we have, in coordination with DHCS, included those in our primary care definition. There are also some additional changes we've made based on the board discussion in June. And again, those are highlighted in green. And then moving on to care settings on the next slide. So here, we require in our definition that all three pieces of the definition be met for claims-based services. So these sites include both traditional primary care locations as well as home and community-based sites. And of note here, Retail and urgent care clinics are not included because they do not typically provide coordinated comprehensive care. And on the next slide, we'll recap our non-claims based primary care measurement approach. This slide provides a high-level overview of the proposed approach for measuring non-claims payments using HCI's expanded framework categories. So OCA developed this approach in collaboration with the investment and payment work group, and I won't review this in detail since we reviewed it in May and June, and we're not looking to make any revisions based on public comment or board feedback. I don't think we received any kind of concerns or suggestions for revision to the non-claims spending approach. So we just included this to provide a comprehensive look at how we are approaching the definition. And for more detail, there are more detailed slides in the appendix. And then if we move to the next slide. So in our work group discussions, we identified several areas for additional analysis to complement the primary care spending definition and supplement the data that we're gathering from payers. So OCA will pursue these analysis using HPD data as feasible. So some examples include, like we've discussed previously, tracking primary care services delivered by OBGYNs using our current proposed definition or with a modified list of primary care services. And again, measuring the portion of OBGYNs providing primary care consistent with the work group's vision. Monitoring primary care spending if not restricted by service or place of service. And then spending on primary care services delivered at retail and urgent care sites. So these are the few analysis that we'll look to use HPD data to conduct. And then now we'll transition to recap our recommended primary care investment benchmark and then open up for board discussion. So on the next slide, again, you saw this slide in June, but just wanted to reiterate a few highlights from other states who are working on investing in primary care. So in Colorado, they are working towards primary care investment, and some of their focus has shifted from primary care investment to encouraging alternative payment model adoption, which may explain the lack of increase in primary care spending there. Delaware's progress has been prompted by several factors. So that, they have statutory requirements for minimum fee-for-service payments equal to Medicare rates, increases in overall investment, and similar to Colorado, primary care increases in primary care non-claims or alternative payment model payments. And in Oregon, their success has primarily been driven by their patient-centered medical home initiative, which increased primary care spending in that state. Oregon also has a lower total cost of care than many other states, a broader definition of primary care, and it excludes pharmacy from the total cost of care denominator, all of which increase their spending percentage in primary care. Here, Rhode Island slowed total healthcare spending with price growth limits while primary care spending increased. So this is similar to what we saw earlier in the health affairs study, and it has also benefited from robust care transformation initiatives. And Connecticut has faced some challenges as total medical expenses increase have outpaced modest increases in primary care investment. So these are some highlights from other states that have been working on primary care investment, and then we'll move to recap the data we have for primary care investment in California. So you have seen the slides we're showing here before, but just wanted to recap again to frame our discussion of the benchmark. So this slide highlights the Medi-Cal health, how much Medi-Cal health plans spent on primary care in 2018, which was an average of 11.3%. And here I want to emphasize that the Medi-Cal report used a different methodology than OCA is proposing, and it used a different data source. It used the Medi-Cal rate development templates as the data source here, where we would be collecting data from payers using our methodology. And so we expect that the percent investment that OCA calculates will be lower than what this methodology produced. And then on the next slide, we'll look to commercial and Medicare Advantage spending. So again, you have seen this slide before, and it shows data from the Integrated Healthcare Association. So the combined commercial spending in that darkest blue bar and the spending for Medicare Advantage, which is in the green bar, are similar, both hitting the neighborhood of 10% in 2021. And this slide also highlights that primary care spend differs by adult and pediatric populations, and the higher pediatric primary care spend informs our recommended investment benchmark. And then we note in the appendix that OCA, and you'll see the details more in the appendix, that OCA expects that the differences between the IHA and the OCA definition will result in slightly lower percent primary care spending as measured by OCA. So if we move to the next slide, again here, wanted to show you this slide again, is data from the Integrated Healthcare Association from 2021 that shows spending across HMO and PPO plans. So in HMO plans, the spending tended to be higher with an average of 9.2%, and among PPO and EPO plans, the spending averaged about 6.3%. And both types of product had a broad range of investment levels across plans, and the differences in spending across product type here inform OCA's recommendation that the annual improvement benchmark applies to each payer by line of business and product type. And then wanted to provide one more slide before we get to our proposed recommendation for the primary care investment benchmark. So this slide, again, you've seen, just shows an example of how reallocating spending across the healthcare system could support increases in primary care spending. And this is really driven by statute that specifies that an increase in primary care investment should be a shift or reallocation, not an increase in cost to consumers or increase in the total cost of care. So this slide provides an example of the math for that shift. So using a national study, we looked at spending for hospital services, which is in the navy blue, at about 38%, with primary care spending at about 5 to 7% of spending in green. So in a hypothetical example, if we shift 1% of total medical expense from hospital to primary care, it requires a small decrease in hospital spending, about 2.6%, and the resulting increase in primary care spending is between 14 to 20%. So reductions in avoidable emergency department use or avoidable hospitalizations are examples of low-value care that can be addressed through greater investments in high-value primary care, and reallocation of spending from low-value or unnecessary care to primary care could come from other sectors of the healthcare system, not just hospitals, but all with the goal of reallocating unnecessary or low-value care and reducing that care and increasing investment in primary care. So moving to our recommendation. So this is OCA's primary care investment benchmark recommendation. And we are proposing two related benchmarks. The first is an annual improvement benchmark that will begin in performance year 2025 once primary care data collection has begun through 2033. For this part, each payer would need to increase their primary care investment by 0.5 to 1% each year by line of business and product type, depending on their starting point. And the second part is a statewide investment benchmark for 2034. For this part, California would need an average of primary care spending of 15% across all payers, lines of business, and products statewide. So in this blue box on the side, we've included the rationale for this draft motion. So the benchmarks here have received strong stakeholder support both from our work group and public commenters, and they give payers a reasonable opportunity to demonstrate immediate progress while making sustained success. And the 10-year time frame for the statewide benchmark offers a gradual glide path to meet this ambitious 15% goal. We note that some board members have expressed interest in seeing faster progress early and wanted to discuss some of the trade-offs. So a benefit would be more dollars going to primary care earlier to fund infrastructure development and workflow redesigns. And the trade-off so would be that it takes time for providers to shift care delivery to really maximize that level of investment. And research has found that the full benefits of increased investment in primary care do not occur immediately, and that payers will be balancing these increases with efforts to slow growth in total spending. Of note, the 10-year timeline also aligns with our timeline for the OCA alternative payment model adoption goals, and the APM adoption and primary care investment work streams really complement each other and work together towards improving value by supporting delivery system transformation and helping moderate spending growth. And finally, the benchmarks offer flexibility with the timeline since OCA does not have an exact level or an exact measure of primary care spending using its current definition. So these two benchmarks are our recommendations for primary care investment. And so I'll pause here for discussion.
Great, thank you, Margarita. Ian?
Yeah, two questions maybe scrolling back to the charts from the different states. You know, I love the formulation that we choose to not spend an extra dollar in hospitals and use some portion of that to invest in primary care, but without a mechanism to direct that. The skeptic in me says, how is that going to happen? And yet the Rhode Island example, I think a lot of that period of escalation overlapped with the period that they were applying price controls to hospitals. Something happened there, and it was pretty remarkable. So two questions. Do we know if Rhode Island had additional teeth to direct some of that investment? And B, given that this has happened over many years now, is there evidence that that additional investment in primary care has resulted in kind of overall improvements in population health?
Yeah, Mary Jo, do you want to address that? Thank you.
Sure, happy to. Can you all hear me okay?
Yes.
Okay, great. Yes, so the Rhode Island experience, I think, has been really interesting. So you see kind of that gradual line there, and that's because they did have this gradual sort of 1% increase per year. And you're right that on a parallel track, they also had the price growth limits that Vishal mentioned earlier, which essentially say for hospital costs, they cannot increase more than CPI plus 1 on an annual basis. That worked really well for a long time before CPI went up really high, right? And by the way, Delaware also has that same requirement in place. One of the things that is a little bit unique about Delaware and Colorado and Rhode Island and Oregon is that they all have a primary care investment requirement. So there's something actually in regulation or statute, or in some cases both, that does give them that little bit of extra teeth to sort of push that forward. One of the things that's different about Rhode Island and Delaware is they have what I like to think of as a defined offset. So they have something specific in place, some policy mechanism specific in place that is supposed to offset the increased investment of primary care. So for example, both of those have that CPI plus 1, which worked great until it didn't. And so they're sort of working on thinking about what they might do next. In Oregon and in Colorado, it's a little bit different. So Colorado doesn't have that defined offset. And although their insurance commissioner does have some regulatory authority, it perhaps has not been used always to its full extent, or maybe it's being used in other ways that we don't see publicly. In Oregon, a lot of the sort of cost pressure there comes through contracts that they have with their Medicare, with their Medicaid managed care organizations, in which those contracts are supposed to sort of simultaneously increase this primary care investment while not increasing total costs. All of these states, if you went to those states today, they would tell you that there's been really great things that have happened
not so great things that have happened. There's no sort of like perfect success story. But I think one of the things that Rhode Island has in place that has been incredibly helpful is a strong sort of statewide buy-in into the idea of increasing primary care investment, and a lot of just incredible voluntary multi-stakeholder collaboration that's actually convened by a non-governmental organization called the Care Transformation Collaborative. I think we see some similar things here in California, where so many of the state purchasers have come together to work together on these initiatives.
Dr. Pam?
Thank you. So first of all, thank you so much for the presentation. In some ways, I'm sorry I wasn't able to be present in June during that discussion. Couple of questions. First of all, in terms of future analyses, I think one of the things I did bring up at an earlier board meeting is that while certainly we want to increase the overall percentage of primary care, I think what primary care spend, one of the issues was what we really want to be sure is that, let's just call it the sickest 10%, right, who spends 2/3 of all the healthcare spending, right, that they're getting access to advanced primary care. And so I'm hoping that as we're looking at future analyses that we might be able to particularly do that. That's where, if we're going to try to push for acceleration, where we're going to have the biggest bang for the buck, right? Right. So, I mean, someone who's perfectly healthy, they certainly benefit from having primary care, but your cost savings are going to be probably not that significant. You're talking somebody who's has a significant healthcare spend, who needs that coordination care, et cetera. That's where the opportunities are. So hopefully we can look at where the primary care is in that group. If it's very high, great. If it's low, then we got a lot of work to do there. So I just want to put a pin in that. The other thing is that so I know we don't have a specific enforcement mechanism, right, for these primary care benchmarks, but I guess I'd pose the question, we create the benchmarks in a future corrective action plan, or whatever you want to call that, that if someone exceeds there, would we actually go to a health plan and said, well, one of the things we would need you to do is increase, you need to be at your primary care benchmark, right, as part of your response. Is that something that's envisioned in this process? So even though we don't have an explicit, if someone exceeds your cost target, would we look at that as a tool to try to push people, a plan or risk-bearing organization to increase their primary care spend?
Yeah, absolutely. So thanks for bringing up the enforcement issue. So those are the two main tools we have on enforcement. Well, the first is just the transparency piece, and then the other is, yes, if we had an entity that exceeded their spending growth target and wasn't hitting the primary care benchmark, that would be included in the performance improvement plan.
Okay. I appreciate that, and certainly think that's something to consider, but that also heightens my concern about excluding OBGYN. Right? If we're just doing a benchmark and we exclude it, so fine, spend will be a little lower. But now we're basically going to tell plans that even though in statute OBGYN counts for your primary care provider, it won't contribute to your primary care spend. And if you happen to go over the cost target, you got to push your people from picking an OBGYN because they won't be counted. And so that is concerning to me, especially in a time where we're having a national debate about reproductive health, all right, family planning, et cetera, maternal mortality, et cetera. And we're sort of saying services that, now I agree that not every OBGYN, nor is everything that an OBGYN does necessarily fits there, but there's a lot that they do. And that's part of, we've had policymakers been having this debate for a while. But I do think that I'm concerned that we're sort of leaning in the other direction, especially if eventually we're going to use a hammer about that we're going to give people an active disincentive to, even though we have in statute that you can pick an OBGYN as a primary care, we're going to be telling you, well, if you do that, you still could face a penalty because none of the services that they provide will count under its primary care benchmark. If you happen to go over the target, that's one way to fix it, right? Is that let's find ways to discourage people from doing that. And of course, that has a disproportionate impact on on women. So I am concerned about sort of the sequence of events that could happen in relation to that. And sort of going back to the diagram that in terms of how we finally decide how to calculate it, it's not that, oh, if you're a particular type of physician, whether it's OBGYN or something, that automatically everything you do falls under this, right? Because you showed that path, right? You basically go, and then we look at the place of service, and then we look at the actual services. So, part of me is sort of thinking like, well, a lot of what OBGYNs do, well, I guess the question is, what do you consider pregnancy, right? What do you consider family planning? And if it's, and so shouldn't some of that fall under? And in fact, actually, interesting enough, in the services, we have even a whole section on women's health services in that slide. So I am having concerns about this idea of excluding OBGYN. I hear if you certainly create a whole separate category for them, that's an increased burden on the data collectors. But even if we just follow the same path that you're doing for all the other physicians, I guess the question is, I guess there might be some concern that you may overcount, but are we really thinking that's going to be a huge overcount? And I think, and I'm concerned about the danger of the other way, which is the undercount, especially if we're going to eventually use this tool, this benchmark, as a tool to basically push plans to behave in certain ways, or other risk-bearing organizations. And there are, and we are in that way potentially taking away choice from people who wish to choose, who currently are choosing an OBGYN as their primary care physician, who at that point for the plan, technically, they are responsible for providing all those services, including, mental health, other types of things that they have to coordinate. They may not deliver it themselves, just like any other primary care physician.
Thank you very much for raising all those issues. And I just want to note that I think this has been one of the harder issues. And so I do want to spend a minute talking about it. When the team first presented this to me, this was one of the significant questions that I had, was about why we weren't including OBGYNs. And so I asked a lot of hard questions. We had an in-depth conversation about it. As you know, this administration is very committed to women's reproductive health, women's overall health. And certainly I know my own personal experience was during my 30s, most of my time with providers was with my OBGYN. And I agree with you, certainly during pregnancy, there is comprehensive care being provided to many pregnant women. And so I think part of this is a data challenge. I think we're committed to, re-looking at it in a year when we're able to do this HPD analysis. I certainly appreciate the point that if we're using this as an enforcement tool, potentially down the line, it does, increase the stakes. So I want to be very clear that this in no way undermines the value that we place on the work and services being provided by OBGYNs. And I think, again, Margaret and I did meet with ACOG last week, to hear their additional perspectives, heard from a number of their members, and those are important ongoing conversations for us to be having. I think on balance, we continue to think that because this is a focus on whole person coordinated comprehensive care, that many of the services that gynecologists provide don't meet that standard, but it is something that we're certainly going to, continue to, we're very committed to relooking at it in a year and continuing to look at the data. I don't know if there's anything you want to add.
I think I'll just add that part of the nuance is exactly what you mentioned, Dr. Pan, is the challenge of overcounting or undercounting depending on whether we include or exclude OBGYNs. And I think for the potential overcounting is if including OBGYNs in our definition, all office visits, all evaluation and management codes billed by OBGYNs would count towards the primary care investment spending. So that is one piece that would lead to potential overcounting, and that could include more specialized care.
I also want to say, as someone who has spent much of my career committed to the enforcement of the Knox-Keene Act, including 4+ years at the Department of Managed Health Care, that I am a little troubled of the suggestion that you made that plans could somehow push women away from choosing OBGYNs as their primary care provider, which would be a very serious violation of the Knox-Keene Act. And I'm sure I speak for the administration to say that that would not be tolerated. So I think there are important protections in place. As you very, very well know, there's network adequacy protections as well as the ongoing right of someone to choose an OBGYN as their primary care provider.
Well, I'll just briefly say, when we provide people with counter incentives, you do see behaviors. I agree with you, right? That as a regulator, you'll try to stop that, and certainly in overt ways. But we also know that people behave in other less overt ways when they know the incentive is for them to do that. And I'm concerned that we're giving we're giving the wrong incentive there. We're basically posing potentially an incentive to do that opposite, which would not be consistent with our other policies. And that is concerning to me, but thank you. I appreciate that. I agree that, yes, I trust our regulators will try. And if they see anyone's too overt, they will act. But, we also hopefully, I don't know, maybe I spend too much time studying human behavior, but, we give people incentives, they follow them. And if they can't do it overtly, sometimes there can be more subtle ways. And we actually see this, of course, for in a lot of places. So thank you.
Elizabeth?
Thank you. I wanted to compliment you on the presentation, and I appreciate also you setting out this vision for comprehensive primary care at the beginning, which I actually think does lend itself to the current approach in terms of how we think about OB/GYNs as well. So I thought that was great, and I'm guessing I was one of the board members referenced talking about moving at a faster pace. So I guess, and I think a 10-year goal is probably set by someone younger than me, but I would recommend that we also publish annually, if you're not planning to already, those who are moving faster. So we're not just wedded to this bare minimum standard of 1% a year. So, because I think it would be great to see who is actually exceeding that.
Yes, we would, our intention is to publish, the primary care spending by payer, line of business, and product type each year, and show those that are meeting the 0.5 to 1% annual investment benchmark. So we'll be both their primary care spending level and whether they've met the percent increase.
But will we also know those who maybe go for 2 or 3 or okay? And then will you also be looking at sort of the implications for their practices? Because I heard you say that one of the concerns is practices aren't ready. I would like to see what happens when they do get the resources and the technical assistance, because I think they can actually do more than we're assuming.
I think that would be one thing we would need to do in collaboration with purchasers and providers and payers. So I think we're happy to continue that discussion and work with payers and providers especially.
Don, Rick, anybody? Good?
Following on Senator Pan's comments, Elizabeth and Margareta, you've each referred to the sort of data difficulties around OBGYNs. I think it would be helpful for me, and certainly I'm sure helpful for the ACOG, and the many people have written me letters about this, as I'm sure they've written many other people, to have a better understanding of that, of those difficulties. Oregon, we saw on a previous slide, does include OBGYNs, I gather, in their definition of primary care. Sort of what are the problems with what Oregon has done, and why wouldn't it work here? Margareta, you mentioned the difficulties around non-claims payment. I understand that. That seems probably relatively minor. If that's the thing that's holding us back, I would think we could, put that aside for some number of years. Maybe that's a wrong thought. Margareta, you mentioned the difficulty of assigning every evaluation management service to primary care. I'll show my ignorance about California billing for OBGYNs. In other states that I've worked in, almost all the billing for pregnancy-related services is global billing. And there's not, you don't see billing for individual E&M services. Maybe that's not what happens here, and that it really is a problem. But all this to say, sort of simply saying there are data problems, and for me is not quite enough, and I'm sure for ACOG is not enough, and a fuller description of those problems, as well as, you've mentioned the HPD analysis, sort of a clearer path forward would I think be helpful. Because I mean, you said earlier that it's unknown whether OBGYNs typically provide primary care. I'm not sure that's right. I think it's known that they probably don't typically for most of their patients, right. But it is also known that some OBGYNs do provide primary care for some of their patients, and sort of figuring out what the path is to be able to measure that would, I think, be helpful moving forward.
Sure. So I'll say a few things. So among the states that measure primary care spend, or states and national definitions, many of the definitions do include OBGYNs. There are few that exclude OBGYNs completely. And then there are some that count OBGYNs as primary care, but have a more limited set of services. And that's the piece I was referring to in terms of the data complexity. So essentially, if we created multiple definitions, so we had one definition of primary care spending for all other designated primary care providers, and then one definition of spending for OBGYNs that included a more limited set of services, that would be the data complexity in terms of collecting spending in two definitions from payers. So that's one piece of...
Following on to Senator Pan's earlier question, what would be wrong with simply applying the current definition to OBGYNs?
Is the piece that I mentioned earlier about potentially over-counting primary care spend, and the same piece that you mentioned, that some of the care provided by OBGYNs is not considered primary care traditionally. So more specialized care, office visits that are intended to treat more specialized OBGYN services and conditions for women. So those are the types of care that we would be over-counting if we included OBGYNs in our current definition. I don't know, Mary Jo, did you want to add or expand on that?
Right. So I think the difference is if I go into and they do a depression screening, and they do a violence screening, and they do a pap smear, that's all preventive care. If I go in for uterine fibroids, that wouldn't be primary care per se, and so we'd have to set up a different set of rules than we would for primary care providers.
Yeah, add a diagnosis piece to it probably.
Correct.
Yeah.
So let me maybe weigh into this as a primary care physician and someone who has heard the feedback. Appreciate, Margarita, all the work that you've done. I know the advisory committee spent quite a bit of time discussing this as well, raising a number of the issues that we've talked about here. I agree with Dr. Pan that the real vision for primary care is to try to get the folks who have really complex chronic conditions timely access to primary care. That is why we're doing everything that we're doing. And while there are OBGYNs who do some comprehensive care, the majority don't. And so I appreciate OCA's staff coming back and saying we will use the HPD to begin to collect the necessary information to perhaps revisit this decision down the road. Maybe we put a marker in terms of when we might do that, since we don't yet have a baseline. I want to acknowledge that it is super important to get reproductive health care services to all women in California. This is not in any way, shape, or form a statement that undermines that. I think all of us in the room could agree to that. And so I'm supportive of the staff's recommendation. Appreciate the desire to come back and use the HPD data to better understand it. I also spent a little bit of time looking at the dashboards that are used nationally. The National Academy of Medicine has a full report on primary care. That report identifies primary care providers. It does not include OBGYN providers. And so for me, that helped me sort of think about how we're going to measure ourselves first against other states, but also just looking at what the national goal is and what the ultimate goal is here, which is to make sure that folks who have really complex conditions get integrated, comprehensive, whole person care, which largely, if not overwhelmingly, are provided by the primary care providers that we've identified in this recommendation.
Yeah, I know. Well, given the fact that you, I just want to figure out how you're operationalizing this because you talked about you're going to be collecting additional data. So going forward, and obviously depending on what we do here, but I assume we're going to go and collect this data to try to establish a benchmark. Are you going to collect data with the OBGYNs, perhaps, and again, to reduce the data complexity, just include the data, but run it through the same filter as you would for, let's say, the other physicians and NPs and PAs, and tell us what's the difference. So yes, it may be an overcount, but if you're actually doing a study on, well, how big is the under overcount or whatever, then you would be doing that anyway. So are you planning to do that and would be able to see that data when it's done?
So what we're proposing currently is to collect data from payers as a subset of their total healthcare spending data submissions for primary care spend using our proposed definition, which currently recommends excluding OBGYNs, and separately in the HBD do a more detailed analysis of the types of care and services that OBGYN providers provide. And like, what is the portion of their services that include kind of comprehensive chronic condition management, those types of services. So do that deeper service analysis using the HPD data.
So, but will you, as part of that, also perhaps collect the version of the data, which hopefully shouldn't be too complicated because it's basically just adding another, like, okay, so we're going to do it with these, they're not. OBGYN's pretty well defined, who's got, and say we're going to run it through the same filter as we do all the other physicians and nurse practitioners, PAs, and say how much of a difference does that make? So we at least have a sense of the magnitude.
We don't currently plan to collect two different sets of data with two different definitions from the health plans on this issue. And I don't want to speak for the payers who will be submitting the data, but I mean, we are, working closely with them collaboratively and trying to reduce administrative burdens, both on our team, on their side. So we plan to use the HPD to do the analysis, not to collect two separate sets of data from the payers.
Well, okay.
But Dr. Pan, I think you're asking, will we see the HPD data? Is that what you're asking?
Well, that too, yes. But I was just, I mean, it's not that when you say two separate sets of data, it's essentially a piece of data and one that's slightly augmented for that one field. So, so we at least know what the magnitude is. Not,
Don, do you want to wait?
Yeah, go on, Don.
Oh, there we go. Now it's on. Green on. So, Margaret, a terrific presentation per usual. These have all been great, so thank you. A question. So, you're proposing to differentiate the expectations by product line, if I understand it correctly. So, for example, because there's lower primary care spend on the PPO side, the expectation is commensurate progress, but starting with a lower benchmark, right?
Sorry, yes.
So I want to make sure that I got that right. So I guess one question, maybe question suggestion, is that I think there's probably in some spaces more bang for the buck, and ultimately, so if we're comparing an integrated health system, for example, with a Wild West PPO, the differential is much more meaningful. One, it's going to be harder to achieve in a system that is already doing a great job with primary care. And two, it's going to be more meaningful in the case of the PPO with very low numbers. And so I would think about about maybe staggering this so that I appreciate that we're not going to expect a PPO to get to an integrated system level overnight, but I think ultimately the goal is to have them in similar places. I get that it's harder, but that shouldn't mean that we're trying to do it maybe over a longer period of time, but not that we should be expecting less. So I think it would be helpful to think about a path so that we're getting to more comparable numbers over time for all product types, because it shouldn't matter. What matters is the patient's perspective, and whether there's enough of an investment there, not how well they're doing compared to either high performance or very low performance. So maybe, maybe I'll just make this up. You expect a point improvement on the PPO side and a quarter point improvement on an integrated system type or an HMO, so that over time they catch up and you have it comparable. Just something to think about. The other thing that I would think about is the question of like what's the right number here. So how much can you wring out of the system in terms of low value care, and how much can you get out of high value primary care? And that probably, hopefully that number will change over time, but we want to kind of think about that and have that informing our thinking about the trajectory, rather than not having an answer to that question going in. So I don't know whether we have a hard answer there, and as I said, I expect it would change, but there's probably things we can know in this space, and it might be it might be helpful to do that to the extent possible. Rick is shaking his head. I'll let him.
If I may.
Please.
I mean, I sort of agree, but since we don't even know what the number is now, to sort of think about what's the right number is hard. I mean, this is this is directional.
I agree, but it's also but we know there's a number there, and
the right number is also and this I mean you've suggested paying attention to differences across product types, PPOs versus HMOs, which certainly makes sense, both on level and rate of growth. I think we also should be paying attention to differences across population types. You pointed out that, in the status quo, primary care is a much larger fraction of spending for children than for adults. There's a reason, and they're never going to be equal. And you showed also on the Medi-Cal data, much lower fraction of spending for people with disabilities. And again, we shouldn't expect that to be equal. And moving forward, I think sort of paying attention to those differences, understanding them better, and not expecting everything should be equalizing makes sense. And then while I have the floor, just sort of respond, Dr. Pan, I think, collecting a second set of data from the payers, to me, does not make sense. It would be burdensome, and doing the HBD analysis, trying to figure out kind of where we are and what difference it might make from that makes sense, and then potentially changing the request from the payers is I think a much more sensible way to go. My earlier comments were just to try to encourage a little more specificity about what that analysis might look like, what the timeline might be, and also a little more clarity about which you provided here in part about sort of what's wrong with what gets done currently in other places.
Can I add one other thought, unrelated? So purchasers are starting to think a lot about the difference between high value and not high value primary care and paying accordingly. Elizabeth has members who have made great strides in this space with some terrific results. We're also trying to think about as we think about paying, about what our expectations should be in terms of return and building that into contracts. I think it's really critically important work, and I think As we continue down that road as payers, it's going to be important to have a dialogue between the payers and OCA so that that's reflected in our thinking about primary care spend.
Thank you, Don. Richard?
I think that I think as we look at different populations, I think we have to recognize that if we set it as simply a percentage, I mean, it works globally, but the reason children, you see a higher percentage is because we don't spend as much on the other side because, children fortunately are not as sick usually, and hopefully we never get to that point where the children are sicker than adults. So when we think about a percentage, and we think about specific populations, again, people with disabilities, right? Just because they have a higher demand or need for essentially the non-primary care services. So certainly a percentage is one approach, but I don't know whether we should think of, as we study things, more sophisticated approach, particularly for subpopulations and also the ones who benefit the most, right? So is it not just only a percentage, is there perhaps a certain amount of spend for high value primary care, right? In other words, what is the primary care center actually doing? Are they delivering the chronic care model? Are they doing, are they doing the patient-centered medical home? Are they, building out the data infrastructure, the staff infrastructure to do that coordination of care? And that also, of course, takes time too. But the goal is not that that center is going to do 100% or 50%. It's going to be that they've built a certain level of infrastructure. And if someone has a lot of specialty needs, those are still going to be provided by specialists. So hopefully we can think about a more sophisticated model, perhaps when we look at specific populations or targeted areas. I think percentage is fine for this really broad approach to say we need to bump up the percentage, but we may want to think about, especially when we think about who would most benefit, a more perhaps sophisticated approach in figuring out what's the right target.
Yeah, Dr. Pan, regarding that, I think that's a good point. I think that's kind of a next step after we do the data analysis and publicly report it. And the payers that are doing well, OCA would want to meet with them and find out what their primary care strategy is and what specific models you are implementing so that we could highlight those at a board meeting in the same way that we've been inviting entities to come present on their cost reducing strategies.
Ian?
Yeah, if just looking ahead to the draft motion that staff prepared here, my understanding of that draft motion, especially since where the rubber meets the road on these questions is with performance improvement plans, that there's flexibility built in there to not expect things to be equal on an age-adjusted basis or plan design basis. So at the appropriate moment when you want to move forward, I'd make that motion.
I'll entertain that. Ian, you want to make?
I'd move as the staff have recommended.
Is there a second? Second, Richard?
Since we're moving already to the motion, then I would ask that we divide the question. So I would like to separate the benchmark percentage themselves from the definition and make them two separate motions.
So I should clarify that the definition is actually an office decision, not a board decision, and the benchmark is the board decision.
Yeah, the motion is only for the benchmark, Dr. Pan.
Okay, then I'll vote accordingly. Thank you.
Okay, great. So there's motion. Let's take public comment unless there's anything else from the board.
All right, we'll now take public comment on this item. If you're in the room, please step to the podium. If you're online, please raise your hand. Please limit your comments to this agenda item. And you'll have 2 minutes for public comment. We'll look online. Kate Fisher, I see your hand raised. Please go ahead. Kate, you're unmuted on our end. You'll need to unmute on yours. There should be a button in the top right-hand corner of the screen.
Hi, can you hear me?
I can. Go ahead.
Sorry, that took me a moment. I apologize. My name is Katie Fisher. I am presenting as a private citizen. I think there's been, and I'd like to comment about the definition question. I think there is a fundamental misunderstanding about how women receive their primary care, it's been my experience that if you happen to see a family practice physician, they do the full range of primary care, women's health care. If you see an internist, they do not. They do not do abstinence and they do not do a variety of other things. So you do have to go see an OBGYN. In addition to that, pregnant women do not have access to their normal primary care physicians. If you are pregnant and you have a cold, you have a rash, you have an earache, you have the flu, you don't go to your primary care doctor. You only go to your OB while you're pregnant. So leaving that out of the equation seems very short-sighted. But in fact, it does, I think, make sense in the context of that, for more than a century, women have been totally excluded from health studies and health data because they were too difficult to collect data on or too hysterical. And so by excluding women's health care and OBGYN care, they're just continuing a long line of women's health and primary care needs. We can just wait another couple of days for the moment to come into value collecting women's health. We'll just wait.
Kate, Kate, I apologize. This is the facilitator. I'm going to pause you right there. We're having some technical difficulties in our room, so it doesn't sound like it's on your end, but the volume is making it impossible to really hear you clearly. I know that we are currently troubleshooting this, but I don't want to miss your comments. So I might pause for a moment, and if it's okay, I'm going to go to the individual at the podium, and I do see 3 more hands raised. And Kate, I'll certainly come back to you. Apologies for that.
Good morning. My name is Anate Millers, Director of Regulatory Affairs at the California Association of Health Plans, representing 42 Knox-Keene licensed health plans in California. Generally, CAP supports OCA's goals to promote, measure, and report primary care investment. We agree with the notion that increasing primary care investment will help bend the cost curve over the long term, and we appreciate the discussion today around nuances of measurement and potential flexibilities. With that in mind, payers continue to express concerns about the realistic achievability of a 15% level of investment in coordination with a 3.5% spending target. When evaluating entities' spending target performance in the future, OCA should consider that the pathway to a year-over-year 3.5% spending target plus incentives for higher reimbursements for primary care may result in higher costs in the short term with potential cost savings over a much longer term. As this process moves forward, we encourage OCA to continue learning from other states that have implemented similar benchmarks so we can recognize any limitations and properly address them. And as suggested during today's discussion, we hope OCA will continue revisiting the benchmark methodology based on early year experience. And we look forward to continued dialogue with OCA on that subject. Thank you so much.
Thank you. We're still working on that, but I'd like to move to Steve Shortell with your hand raised, and we'll see if we're able to hear you okay. Go ahead.
Okay, I wonder of the Maryland experience. I realize they don't have a primary care investment target as I understand it, but as we know, they've been under global budget for some time on the hospital side in particular. It'd be interesting to know those hospitals who've stayed under the budget, whether it's because they have more investment in primary care to keep patients out of the ED and hospital bed when they don't need it, or if they've redirected any potential savings towards even greater investment in primary care. And my understanding is they also now, with their global budget approach, have a primary care initiative as well. So maybe looking into Maryland would be interesting to do, and we could learn from that. Thank you.
Thank you. I do note we are still having some technical difficulty in the room hearing our call-in folks, but we are able to hear some of them. So at this point, we'll continue with public comment. I see another hand raised virtually. Marielle, please go ahead.
Hi there. Can you hear me? Okay.
We can. Thank you.
Okay, thank you so much. Hi, my name is Dr. Marielle Reyataza. I am here representing the HCA Advisory Committee on my first term, and I'm also the Executive Director of the National Asian Pacific American Families Allied for Substance Awareness and Harm Reduction. I really appreciate the discussion on increased spending and focus towards primary care, although I am concerned, just as Dr. Richard Pan had mentioned, that if we don't include OBGYNs in this primary care discussion, I fear that we will be really misunderstanding or have a strong lack of understanding of how women and our and girls are accessing services. Not only are many services coordinated by OBGYNs, I think it goes to show that for those of us who have some kind of HMO plan, it is already very difficult to access our primary care providers. Oftentimes we have long wait times, and for for many women, especially because a lot of women's health and issues and reproductive health are often not well understood as other types of health. I fear that a lot of care would really be lost in not including OBGYNs as primary care providers. So again, I thank the board for considering this, but I hope that this can also be addressed because, we know that more people are insured. That's great. That's true. But there's a whole lot of people who are underinsured because they cannot access their current primary care providers. There's long wait times and because of high deductibles annually. So thank you again. And I hope that this point will be reconsidered and revisited. Thank you.
Thank you. Going to the individual at the podium.
Ryan Spencer on behalf of the American College of OBGYNs, District 9. I'd first like to thank the staff and the Director Landsberg for the time they spent with ACOG leadership last Thursday to hear their concerns regarding the exclusion of OBGYNs from the primary care definition. ACOG concerns align with what was expressed by some of you during previous hearings and today, but despite a desire expressed to see a recommendation or suggestion on how to include OBGYNs into the definition, I don't feel we've really gotten that and continue to hear only why they can't be included. In measuring primary care spend, we understand it's measured by 3 factors: type of provider, place of service, and service code. And in the case of pharmacists and CHWs, for example, I understand their services would be restricted based on place of service and service codes. I understand it won't be easy to do something similar for OBGYNs. We know it's not possible. OBs would code well woman visits and E&M codes separately during an office visit. And we think it's worth doing to look into that to ensure that women's primary care is not singled out. Also, it's been said here, the goal of the benchmark is to adopt a vision of what the future of primary care should look like and make investments to ensure those types of primary care services are provided in a more traditional or virtual way so that patients have access to the primary care providers. That's exactly ACOG's concern. Excluding OBGYNs from primary care benchmarks means that primary care services they provide will not be prioritized for investment. This could inadvertently reduce support to services they provide, resulting in OBGYNs no longer providing these primary care services and hindering access to crucial preventative care specifically for that they rely on today. No other patient's care, not children, not men, is treated in the same way. Fortunately, we have not heard anyone discount the value of OBGYNs or the challenge the notion that they provide primary care services. We all know they do. We also know some women look and will continue to look at OBGYNs as their sole primary care provider, and others depend on them as a PCP, as was said, while they're pregnant. The current definition will miss all of this, as you guys all know. But here we are, explicitly excluding those services they provided because it'd be administratively burdensome or a data challenge to capture all the primary care.
2 minutes.
If we want to invest in primary care services, we must include those provided by OBGYNs. Thank you for your time.
Thank you. Looking back virtually, I see Kate's hand raised. Kate, I'd like to give you the opportunity to conclude your comments, and we'll see if we can hear on this end. Go ahead.
Hi, can you hear me?
We can. Go ahead.
Okay, I will, I think my other points have been made very capably by ACOG by ignoring the fact that pregnant women do in fact get all of their primary care from their OBGYNs, not their PCPs during pregnancy, and that can take years of women's healthcare lives, and ignoring that data is incredibly destructive. However, it's not surprising. I said earlier, and I'm not sure you heard, so I'm going to say it again because I think it bears repeating. For more than a century, women have been excluded from health studies and health data because they were too difficult or too hysterical. And you are simply here making the decision to continue the long line of ignoring women's health and primary health needs. I guess we'll just wait another few decades for women's health to finally be taken seriously.
Thank you, Kate, and we will follow up offline to make sure that we have all of those comments recorded. Looking back to the podium, go ahead.
Thank you very much. Vanessa Kahina on behalf of the California Academy and Family Physicians in support of the definition put forward by the board staff this morning. There is no doubt that OBGYNs provide essential services for many women and during certain times of a woman's life may be the clinician that she sees the most. And it's clear that OBGYNs do provide some primary care services. Whether they're included or not should depend on the goal here. If the goal is measuring units of care provided, OBGYNs, and for that matter, any other specialty, including cardiologist, dermatologist, any clinician providing primary care service should be included. But if the goal is trying to measure comprehensive coordinated primary care across the lifespan, we should not include OBGYNs. This is not splitting a finger, this is not starting cholesterol medicine or doing a skin scan. While OBGYNs provide absolutely essential services for women, they generally do not coordinate or manage those systems of care across healthcare and body systems. As a member of a payment and advisory subgroup, we've had very thoughtful discussions with most of advisory group members supporting this definition. I know that this has become an issue of contention, but because the data has not been presented previously, we do support the board's recommendation that we continue to look at this through the healthcare payments database. The Knox-Keene Act regulates health plans. OBGYNs are included in that context as a primary care provider to ensure women don't have barriers to access to an OBGYN. That's different than identifying what constitutes primary care. The OCA definition of primary care clinicians will not limit a patient's access to choices or interfere with an established relationship, and for that reason, the ongoing data collection is a paramount piece of this decision. For that reason, we support this recommendation. Thank you for your time.
Janice Rocca on behalf of the California Medical Association. We look forward to working with you to achieve the benchmark that you'll be setting today. In terms of the definition, we remain opposed to excluding all primary care provided by OBGYNs from the definition of primary care. I served on the investment and payment work group where we've been discussing this issue for almost a year. And there has been no movement by the staff, despite the various organizations that have come forward in terms of providing a different recommendation and potential solutions for what eventually became a data problem. It seemed like it was a philosophical disagreement at the beginning and eventually became a data problem. I would say the only change is that the slide that defines which services are primary care no longer says OBGYN services. Now they call them women's health services so that it's easier to exclude the care that's provided by OBGYNs. We're setting up a situation where you could have two physicians in neighboring exam rooms, and one is a family physician and one is an OBGYN, and they're providing the same services all day, and one is included, the other is excluded. We're also potentially setting up a situation where an NP or a physician's assistant who is supervised, has their license supervised by an OBGYN, has that care included, but not the care by the OBGYN. So it's not a system that's going to make a lot of sense. I'm glad that we've gotten to a point where that we'll be looking at it for the next year, but we've been looking at it this year, and the majority of the board members had expressed concern with this approach, including Dr. Galley when it was brought before us in May. And so I'm surprised that we haven't come to the solution of including certain CPT codes now. And if you want to exclude office visits for the time being, but exclude the rest of the services that are on here, including maternity care, particularly when we're trying to attack maternal mortality, but we're going to exclude any maternity care that is provided by an OBGYN. It just doesn't make sense. Thank you.
Thank you. Back to the podium.
Beth Capel for Health Access, like CMA and others, we have served on the investment and payment work group for its existence. We support the staff recommendation on data, and we support the staff recommendation on the benchmark. Part of the reason why you are tasked with doing this is we thought this discussion was better had in this context than in the legislative process, given the reality that we do not yet have good information. So we also appreciate the staff's thoughtful inclusion of collecting additional information. We support excluding OBGYN. Sorry, it's hard to, that's a mouthful. We were involved in the original legislation that has often been cited. It was part of the HMO Patient Bill of Rights that we worked on in the 1990s. I go back again to the language of the law, which was helpfully included by ACOG in their letter. Primary care means providing care for the majority of healthcare problems, including but not limited to preventive services, acute and chronic conditions, and psychosocial issues. So translated into more common language, that would mean that the OBGYN is who screens and treats asthma, diabetes, hypertension, and depression. There may be and the OBGYN is who you call when you have a weird rash or you think you have COVID. There may be some OBGYNs that function that way. We don't think most of them do. We were also disappointed that the law did not pan out as we had thought, with OBGYNs frequently being primary care physicians. It was our understanding in the years since that OBGYNs preferred to be paid as specialists rather than as primary care physicians, which, given the disparity of payment, is understandable.
2 minutes.
Part of what we are here trying to correct. So that vision that the presentation began with is where we want to go. That's what this project is about with respect to primary care. Thank you.
Thank you. Looking virtually, seeing no hands raised and no one at the podium, that concludes public comment on this item.
Okay, so just to clarify, the board, there's a motion on the floor to approve the benchmark investment, which includes the change year over year and the 15% total by 2034. So with that, let's take roll, please.
Dr. David Carlisle. Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson.
Aye.
Richard Kronig.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Abstain.
We have 5 yeses, 1 abstention, 1 absence.
So let me again thank Margarita for an amazing amount of work and for the advisory committee, who I know have struggled with this for some time. We've heard this presentation maybe 3 times, but we really want to appreciate your leadership there. So with that, it is 12:08. I suggest that we take a lunch break and let's come back at 12:45, if we could, please. So let's stand adjourned until then. Thank you. So good afternoon. I think we will reconvene the Office of Healthcare Affordability Board. Let's do roll call, please.
Thank you. The time's now 12:51. Resuming, Dr. David Carlisle. Dr. Sandra Hernandez.
Here.
Secretary Kim Johnson.
Here.
Richard Kronig.
Here.
Ian Lewis.
Here.
Elizabeth Mitchell.
Here.
Dr. Richard Pan.
Present.
Don Molds.
Here.
7 present, 1 absent.
Great. So now we'll consider action item 5B on the agenda, yes? Update on the cost and market impact review program. Turn it over to Sheila.
Good afternoon.
Good afternoon.
So the last time we provided an update to the board was in June, and so we plan to provide quarterly updates on the cost and market impact review program. So I wanted to update you on the material change notices that we have received since the last time we met. So Western Sierra Medical Clinic and Sierra Family Medical Clinic, they are 2 FQHCs in the Placer County and areas up in that area that merged recently because one, Sierra Family was having financial difficulties. So in fact, the attorneys that filed on their behalf did so pro bono. So the 2 FQHCs have merged, and we issued a waiver for that merger. And then the second one is a larger transaction that you may have been hearing about in the news. It is a joint venture between Elevance and Clayton, DeVallier and Rice, which is a private equity firm and they say that they are one of the longest standing private equity firms in history. So Clayton DeBallier Rice and Elevance are both putting funds into a joint venture to create a primary care platform that will serve approximately 1 million members across the country. So how it impacts California is that CareMore was a plan. They're now known as Carelon. Elevance is the owner of Carelon, and Elevance is selling the Carelon plan to the joint venture. So this was a different sort of transaction notice to us because CareMore, as a licensed Knox-Keene plan, filed with the Department of Managed Healthcare, and the Department of Managed Healthcare told Carelon that they also needed to file with us. The DMHC would be reviewing under the Knox-Keene Act, but because this was a larger transaction, more than a plan-to-plan merger or merger among plans, they instructed Carelon to file with us. So it impacts about 31,000 enrollees in Medicare Advantage. So Carelon doesn't have a huge presence in the California market, but as you've heard, the larger transaction will have a bigger impact across the country. So that one is still under review with us, and you may remember that the way we handle these is we receive the notice of material change, we review it for completeness per our regulations. We have often gone back and forth with the submitters to request additional information because it isn't complete under our regulatory standards. Then once it is complete under our regulatory standards, we deem the notice complete, and once it's a complete notice, we post it on the website. And so all of the completed material change notices go up on our website once we deem the notice complete. And then we have 45 days to tell them whether they will receive a waiver and 60 days to tell them whether they would go to a CMIR. So the Carelon, Elevance, Clayton DeBallier Rice transaction is still in review. The Cigna transaction, and this is also one you may have read about in the news, Cigna is getting out of the Medicare Advantage business, and so they are selling all of their lines of business to HCSC, Healthcare Corporation. And so this, again, was not one that impacted a lot of enrollees in California. In fact, Cigna does not have very much Medicare Advantage business in California, so it really impacts other areas, but not California. They were selling their Medicare Advantage plan, their standalone primary prescription drug plan, Medicare Sup, and then this Care Allies business. Some of the Care Allies was I believe Care Allies was a supplemental health and life insurance plan, so regulated by CDI, not DMHC, because whenever there's health and life, it's under CDI. So we've given courtesy notice to CDI as well, but we waived that transaction as well. We do want to watch this one, though, because we do believe that HCSC will be acquiring more business in California. So once these are in our system, we are eventually building a database of transactions that happen in California. So it's really important that we get these notices, even if we issue a waiver, because they're in our system. And as you may remember in our regulations, if you're doing transactions that are similar, our circumstances address that. If it's a similar transaction, similar parties, similar type of services, we can treat them as one large transaction. So, all right, next slide, please. So, Laboratory Corporation of America acquired BioReference, which is a testing laboratory that focuses on reproductive and women's health. And again, this was a national purchase as well. They were acquiring everything except for what was in New York and New Jersey. Our experts reviewed that, and we have waived that transaction. But you may remember that we also received a material change notice, for LabCorp when they acquired Invitae, when Invitae was going through a bankruptcy. So we do know, and again, this is also in the news, that LabCorp and Quest are both buying up a lot of independent laboratories. So again, we'll be watching these transactions, as they continue to unfold. And then the Rehabilitation Center of Santa Monica, that was one we presented to you in June. So let's go to slide 47 because 46 is a duplicate. Excuse me, I felt a tickle in my throat. So I wanted to put this slide up for you, not to read it to you, but per our regulation, these are the factors that we consider when we review a transaction to determine whether to issue a waiver or to order it to CMIR. And we can base our decision on any one of these factors. And you can see that they're pretty comprehensive. And any one or more of these factors may be considered. And so we do read them in conjunction with each other very carefully. Excuse me. And next slide, please. Also wanted to tell you a little bit about, our situation with staffing. That came up earlier. We do have a good-sized staff, and we continue to recruit more. So ever since the inception of our CMIR inbox, we get regular emails. You can see that we responded to 76 email questions, and they are not short and simple responses. We often joke that these are like law school hypotheticals, because if you've seen one transaction, you've seen one transaction. So we're very clear that we do not give legal advice, but we will walk through the analysis for people who submit questions to us, tell them what things to focus on, what things to look at, and we often, will offer to meet. If it's very complex, we'll respond and say, if you'd like to meet with us to discuss this further, we offer to meet, and many take us up on that offer. So, and it's usually not just a one-time question, written response. They will come back with more questions, we'll come back with more answers, and typically it results in a meeting. And I would say that all of the people that we're meeting with are attorneys representing their clients who want to get these filings right. As you can imagine, if they want to get a deal filed and a deal done, they want to get regulatory approval and get the filings done. So we try very hard to provide responses within 48 hours, even on complex questions, and we've done pretty well on that metric so far. So I've also pointed out that we've hosted 16 meetings with potential submitters. 10 of them were with law firms, and what happens is, again, it may be more than one meeting, and there'll be law firms for the various parties. So when we say that these have resulted in 10 filings with us, it's 10 filings, but it could be multiple law firms filing on behalf of their clients, because there's usually at least 2 parties filing a notice with us. And we've just held other meetings with regarding pending transactions to answer questions. Any questions?
Elizabeth?
2 questions. Thank you for this. It's helpful. Can you just remind us about the authority that the AG has? So let's say this goes through, like the one you are considering is referred one way or the other. What is the role of the AG and what authority do they have?
For the
To approve or disapprove or?
So the AG has authority, they monitor transactions of nonprofit healthcare entities. So when they acquire as a nonprofit entity, they have to file with the Attorney General's office. Because they have to file with the Attorney General's office, that means that they do not file with us, all right? So for the transactions that are filed with us, we have the ability to refer a transaction to the Attorney General's office. And we don't have to wait until we're done with our review. If we see something earlier that we think that AG needs to be aware of, we can refer information to them about the transaction. Does that answer your question?
And then what happens?
Then they have the discretion whether to take any action or not. And they can take action based on state antitrust laws, federal antitrust laws, and general unfair business practices.
Okay, that's helpful. That's what I'm asking.
They don't have the ability to deny, per se. They need to.
They would need to litigate. Exactly. So for the nonprofits, they do have the ability to block a transaction, so to speak. They can impose conditions on it, and you've seen that with some of the nonprofit hospital transactions that they've reviewed. But for a transaction that we would refer to them, it would go to litigation. So I call that prosecutorial discretion if they want to take further action.
And will you be updating the board if and when that occurs?
Yes,
Great, thank you.
to the extent that we can, because, you know, the AG, it's law enforcement, and so,
Sure.
yeah, we will share what we can.
Thanks.
Richard?
Thank you, Sheila. Two questions. Other than the Carolyn Caremore transaction, are there others that are still pending that have not yet had a CMIR waived that are being considered?
Yes, we have one where their notice is not complete yet because there's some outstanding information that's due to us, and that is a skilled nursing facility. Oh, go ahead.
Second, I remember when we first discussed this process and the regulations, there was a lot of concern about volume. I'm not remember exactly the number from Massachusetts, but I want to say somebody told us there were 100
Transaction.
filings over some period of time, and I think we said, well, you know, we have 7 times the population of Massachusetts, so we could be looking at, you know, big volume. Are you surprised by what seems to me like a relatively small volume, or is this what you expected? And, or maybe I'm misinterpreting it, but this seems to me like not very much to review here. It is such a big state with probably a lot of things going on.
Yeah, I'm not surprised, and I think I addressed this at an earlier meeting. I'm not surprised because we know that there was a lot of M&A activity in the first quarter of 2024, and we definitely know that there were some very large deals that were completed before April 1st because our statute went into effect April 1st. So we literally did hear firsthand about entities completing their transactions and working day and night to get them done by March 31st. So after that, I think, you know, possibly we've seen a lull. I think there's just a phase-in period where people aren't used to filing transactions with us yet. You know, they're used to in the federal process going through the HSR filing, and we do request HSR filings. But I think that law firms, healthcare entities are getting up to speed on whether they should file or not. And I will say that we are monitoring some transactions. For example, in the skilled nursing facility arena, we are aware, working with our sister departments, of, you know, pending license applications. And so we have reached out to entities that we believe should file with us or should have filed with us. So yes, I think I would say it's a little bit low, but I think we're going to see an uptick, particularly because we've also revised our regulations, and that was effective in August 2022, because prior to our regulatory revision, it was the healthcare entities that were parties to the transaction that needed to file with us. Well, we would often see that the party itself, whose assets or governance was being transferred, wasn't an actual party to the transaction, but it was a holding company that was specifically created to do the transaction, or a parent, or an affiliate, or a subsidiary. So we had covered those to some extent in our regulation, but we revised our regulation so that if a healthcare entity is the subject of a transaction, meaning it's transferring their assets, it's transferring their control, then they have to file with us as well.
And Sheila, can you remind me what happens in the event that somebody should have filed and didn't?
So we could refer that as well to the AG, and they could take the action of potentially unwinding the transaction. That would require probably litigation or a settlement demand, because it would be a violation of our laws and statute. And so the Attorney General could take action based on unfair business practices for not complying with the law. And sometimes those don't go all the way to litigation. It could be a matter of the Attorney General sending a demand on our behalf that they do file. You know, unwinding a transaction is very severe, as you can imagine, and impacts patient care. So we have to really balance that. And so we really are trying to encourage healthcare entities to file. And that's why we try to meet quickly, try to respond quickly, try to answer questions, because in reality, attorneys who file regularly with regulatory agencies, they're repeat customers, and they generally want to have a good relationship with their regulator because they're going to be before them over and over again. So yes, I think it's low. I hope it picks up. I anticipate it will. And I think as we educate more and attorneys get used to filing with us and entities get used to understanding our requirements, we'll see more.
Any other questions from the board? If not, thank you for that, Sheila. Let's take public comment on this item if there is any.
We'll now have public comment, looking to the individual at the podium. And if you're online, please raise your hand. Go ahead.
Beth Capel, Health Access. Just a few notes. First, we're pleased to see this information. We would also note the merger and acquisition activity tends to decline when interest rates are high and increase when interest rates are low. So we would also expect that that would have an effect. As Ms. Tatayan mentioned, sorry, frog in my throat. The Attorney General has the authority to deny, approve, or approve with conditions when a transaction involves a nonprofit health facility. We were disappointed by the veto of AB 3129. It is correct that the Attorney General has litigation authority. I would point to the Sutter litigation, which took 14 years and is still not fully complete. So it is certainly, and some of the review of the data we've looked at suggests that it has not had as much of an impact as we would have hoped on healthcare costs. So the referral to the AG is an important part of what the office can do, but it's not sufficient. Someone should have the authority to deny these transactions. And I will say the studies we've seen, the Attorney General has approved 80 or 90% of the transactions, but almost every approval in the 35 years I've been working on this, Health Access having sponsored most of the legislation in this area, has come with conditions. And there were conditions that made sense, like keeping emergency rooms open and labor and delivery and protecting reproductive rights, as well as now imposing price caps on hospitals so mergers don't result in higher costs. All of that is good stuff, and somebody should have the authority to do that. Thank you.
Thank you. Looking virtually. Seeing no hands raised at this time, going back to the room, if you'd like to make a comment, please step to the podium. Seeing no hands virtually and no one at the podium, that concludes public comment.
Thank you, Sheila. We look forward to ongoing reports in this area. And now we'll turn it over to Deputy Pagani to pick up item 5C regarding our authority to address high costs. Michelle?
Thank you, Vice Chair. So at the last meeting in Monterey, we had abbreviated the board discussion on the item pertaining to Office of Healthcare Affordability statutory authority to address high costs, out of interest in hearing from members of the public. For reference, we've included the same slides on sector targets that we presented in August. Today, we want to allow the board additional time to more fully discuss sector targets as one lever the board and OCA have to address high costs. I won't be going over the slides, but we're happy to turn to any specific ones. We'll, I'll turn it over back over to Vice Chair Hernandez to facilitate discussion on this.
Floor is open on healthcare sector targets. Ian?
Yeah, in the meeting in Monterey was, it was not a culmination, but a milestone in the discussion that we've been having. And in my mind, you won't be surprised to hear, I'm convinced there's a case to be made to have a particular sector defined for at least the 3 hospitals in northern Monterey County. I believe we can move forward with something like that in the shorter term as we shape a more comprehensive approach to what other sectors we might want to look at. As we talk about outliers, I've come to realize, my default thinking when I hear the term outliers is statistical concept, the tail of a distribution. But hearing the testimony in Monterey really drove home to me that we have some important benchmarks for what appropriate costs should be. As flawed as Medicare's reimbursement methodology will be, it is a benchmark. And I don't know if, I've heard testimony that Medicare reimbursement isn't sufficient to cover reasonable costs for hospitals in this state, but there is a number at which that has to be the case. I don't know if that's 120% or 150% or even twice what Medicare reimburses. But to hear hospitals being reimbursed at north of 5 times what Medicare has deemed a reasonable reimbursement rate, just in absolute dollar terms, in terms that lay people can understand, that to me is an important measure. And so, I would welcome the opportunity as soon as the next meeting to set a target, in my opinion, as close to 0 as legally possible for those 3 hospitals in Monterey. But I'd also ask staff, as we think about the overall definition of outliers, to help this board understand, not just in statistical terms, but in more real world terms, what appropriate reimbursement is, what appropriate spending is, so that we can think about what is that threshold. Is it anybody getting twice what Medicare pays? Is that an outlier? Maybe it's not, maybe it's 3 times, but there has to be a number there where we feel, past which we feel spending is excessive and merits its own kind of sectoral treatment.
Elizabeth?
Thank you. I concur with Ian. And I think the evidence, there is actually considerable evidence that shows that, well, first of all, we know that Medicare costs are by law supposed to be cost-based, like they are supposed to be reflective of the cost of the service. And the evidence shows that hospitals should be able to effectively manage at 160% of Medicare max. So even if we went to 200%, like just give them the benefit of the doubt for another 40%, that seems entirely reasonable. And I would be very interested in expediting some of these regional targets. It's not clear to me if by sector we mean region or type of facility, but even if we just started with whether it's hospitals or Monterey or what are they, whichever we collectively decide, I do think there is a lot of value in moving forward with that, because we'll start to understand some of the dynamics that will inform the overall cost target.
Dr. Pam?
Well, in terms of sectors, I think that one of the ones we talked about before, but I think we should perhaps lead with is the geography. And I guess, we talked about the covered California regions. I know the staff has a slide we talked about before, sort of taking LA, doing the spas in LA, but everywhere else. Because again, given the not only geographic, but economic diversity of the state, I think it's going to be important. Certainly, I don't disagree with the idea that there's probably a certain thing related to Medicare. I'd also make note that Medicare itself, some of the rates, depending where you are, a little bit bound by history. What I mean by that is, for example, Sacramento is considered a rural area. We know it's not. All right, so it's the Gypsy 99. So I think that's something we may need to look at. It doesn't mean that someone can be 500% of Medicare, but I think they're looking at things by geography is going to be important, because there are different variations in cost structure in different parts of the state in terms of cost of living, and some differences in markets. And so we're trying to figure out how do we support access in rural areas versus more densely populated areas of different markets. And then, of course, that leads to our ability to sort of drill in and what might be more effective approaches to try to limit healthcare cost growth and improve affordability as well. We don't want to just take a hammer to things, and because we do want to be sure we protect access. So I would say certainly geography, and then of course I think in terms of sectors, we can start delving into thinking about, well, our hospitals and medical groups somewhat different, right? Or other, those are different payers. In fact, in some ways, we were already kind of dividing up the payers, even in our cost targets we talked about, right? If we're carving out Medi-Cal, Medicare, et cetera. So we're already starting to do some of that, even though we didn't formally create different cost targets. We're already creating slightly different rules in terms of what our target applies to in terms of payers. So, but we might want to think about some of those, and I think that was part of the original discussion with the legislation too, recognizing that different pieces are probably going to have different approaches, and frankly, we're talking about trying to get people to increase primary care, right? So now we can sort of do it the way we're doing it now, but one can argue that also from a sector point of view.
I just wanted to address Board Member Mitchell's question. So staff have kind of pointed to this slide. The definition of sector is pretty broad in the statute. It's an include but not limited to language. There's a few examples given for geographic regions, fully integrated delivery systems, and individual healthcare entities. We've included some representative examples here as well for categories of provider organizations, which could be hospitals or physician organizations, categories of payer markets, which could be Medicare, Medi-Cal, commercial, and then individual healthcare entities is like we don't want to subject an entire category of entities to a different target. It's just that we want to narrowly focus on specific entities. So it's pretty broad in terms of what could be done.
Richard?
Thank you. Two comments. One kind of longer term, following on Vishal's comments, and the second, probably more importantly, the shorter term following on Ian's. If you'd go to slide 59, please. This is the longer term comment. To me, for at least for me, the most important entity that I think we ought to be looking at isn't listed here, and that's a health system. I mean, here we are in California, home of health systems, and I know that the fully integrated delivery system is called out separately in the statute, but we have lots of other big health systems in the state, and I would suggest that the probably most important entities to be defining as sectors are health systems. That I know will take some time. We're not ready to do that today or tomorrow, but there are, HRQ has a compendium of health systems. There's been work on trying to enumerate health systems and how would you define them, and I think that's an area that we can and should make progress. The shorter term, Ian has suggested, he's ready next month to adopt a sectoral target, and I would encourage us to move as quickly as we can in that direction. Maybe starting by looking at what would happen if we adopted targets for the 10% of hospitals in the state that have the highest private to Medicare payment ratio. And maybe we can just say we want to adopt special targets for the 3 hospitals in Monterey. I think that might be hard to justify, like, why did we pick those? And maybe the answer is, well, we had hundreds of people come every month. I'm not sure that that's either a great policy answer or a legally defensible answer.
I can think of some other answers, which is that,
John.
I'm sorry. There are 3 hospitals in Monterey County, and a lot of the places where we see high prices, there's a single one that is in a more challenging circumstances than you see down there. So I do think, I totally agree with you. I think thinking about it more globally is the right thing to do. Monterey is front of center because we spent hours upon hours listening to people whose lives were ruined because they went into a hospital, and I don't think anybody in this room can or should stomach that. But we need to be looking more broadly also, because Monterey isn't the only problem spot in California. I do think the other, and you mentioned thinking about systems, the other thing that is worth thinking about, and I think about this when I think about Monterey, is just the interrelation between hospitals and medical groups that operate as sort of quasi systems. So, we talked about when I talked about the CalPERS numbers in Monterey, I noted that we're slightly below average on the professional services side and sky high on the hospital side. But the hospitals own or are affiliated with the major medical groups in that area. And so if you look at the referral patterns, I am guessing you will see that is part of the really high overall costs that you see in places like Monterey too. So it's really critical, I think, that we think about those dynamics when we're looking at particular areas.
Let me just make a few comments. One, I tend to agree with Ian. I think both because of the very compelling public testimony, but also because of the actual data that we saw when we were in Monterey, would suggest that this is absolutely an outlier situation. It is not an only hospital situation. And so I would encourage the staff to think about whether or not we look at it as a hospital sector in that geography, which sort of uses 2 of these criterion, so that we get a handle on that piece of it, and or look at the county as a whole to understand these interactions, especially because we just had this conversation on primary care. Would be also interesting to see how primary care works there. I don't know what the right outlier percentage is, but it seemed pretty clear to me that Monterey is way out there. There are probably other regions as well, but I would encourage us to use this statutory authority and to bring us a recommendation about how we could address this particular situation that seems, I was moved by the public testimony. I think that's super important, but also by the data. And so I would encourage us to lean into this for the next meeting. Dr. Pam.
Yeah, I think there is an approach where we can do geography, and then within each geography, because and we don't necessarily have to. Well, especially in our initial run, we could pick out which geographies where we might go more in depth, where we want to look, also create separate targets for, whether it's hospitals or other entities. Doesn't mean that for every, because I also realize we're having a multiplication problem here for our staff, right? So we have how many regions and then how many hospitals, et cetera. But we could say, okay, we do geography, we realize there's different markets. This was initially created for different markets. And then there's certain geographies where we identified there are particular problems where we might actually drill down a little more and create more individualized targets for particular, provider groups or systems or whatever within that geography, but not necessarily having to do it for every single geography in the whole, simultaneously, let's say, for the whole state.
Other comments from the board? If not, any comments from staff? Michelle, is that helpful?
Yes, we'll definitely be taking this back so that we could, take this into account in our planning for future board meetings. I also do want to, as Director Landsberg mentioned at the beginning of the meeting, we still need to socialize a method for measuring hospital spending. About a year ago, I believe, or almost a year ago in last January, we had our Friedman healthcare consultants come in and present to you about kind of the limitations with the attributed spending attribution approaches, and kind of we need to think beyond attribution for measuring hospital spending. So we do have a provisional measurement approach that we've been working on with the hospital spending measurement work group. Eventually we do need to socialize that with the board and the public. So that's kind of an active work stream as we consider potential planning for sector targets.
Michelle, is that work group a subset of our advisory group?
It's a OCA convened work group, so it's what the department has convened to give input and recommendations to OCA for developing a methodology.
Right, because just to make it obvious, we can't have a sector target on hospitals until we have a way of measuring their spending. So the staff has done a great job. I got a presentation a month or two ago. It only made my head hurt a lot at the very end. But anyway, I think there's a good model there. We'll hopefully present it in the next couple of months. Yes. And
the board would welcome sharing that headache.
Appreciate that. Well, some of you are more data people than I am, but
Dr. Pan?
Actually, technical question. So fully integrated delivery system is its own sector in the statute. Is the staff's interpretation is that suppose, let's say we adopt, I'm just going to pick geographic targets, that we can still have a geographic thing with a fully integrated, there's a subpart of that, or fully integrated delivery system stands aside on its own and it can't be subdivided into other with other sectors.
Yeah, fully integrated delivery system has its own definition. We can't, we would have to abide by the definition in the statute. But you could do sector targets for fully integrated delivery systems. So there could be different values for Kaiser North versus Kaiser South, for example. Yes.
Thank you. I just wanted the clarification what the staff's opinion was on that.
And so just to reiterate the steps, and I think we have a slide on sort of the steps that have to happen, is that yes, to Chairwoman Hernandez's point, we hear your request for us to come back with a recommendation about a potential approach on sector targets. So you would have to give us direction on the sector targets. We have to actually go through a regulations process to define the sector. And then in the spring, the board would, once we have those sectors defined, then the board could set the target.
Could I just clarify so in what form would we need to clarify what we wanted to do to get that regulation going? Because I have my opinions right now.
Michelle, could you just walk us through that timeline briefly?
Sure. And yeah, I just also wanted to go back to Dr. Pan's question about the fully integrated delivery systems. So we'll have to take that back in terms of whether it's more granular than Kaiser North or Kaiser South, because there are some requirements where the fully integrated delivery system can only be subject to one target at a time. So we'll have to circle back on that question next time. And then regarding this timeline, we have a placeholder of to be determined in the first blue circle where we would recommend definitions of specific healthcare sectors at a board meeting. And then, the board would, discuss OCA's recommendations and then honor before. These are the statutory deadlines, and then you'll see the honor before is the flexible language where we could do this earlier. So the board would define initial healthcare sectors, except for fully integrated delivery systems. And then, OCA would need to formalize the board decision through promulgating regulations. And then it would need to follow that same March and June time line for the statewide target where we, OCA would propose targets, but before March 1st, and then the board would have until June to adopt them. And then it would involve that same requirements in terms of public comment and board discussion.
Elizabeth?
So the board would have an action item to define the sectors, and again, we will make a recommendation, and then we put your sector definition into regulations.
Elizabeth?
Yeah, not to belabor, I just ask you to consider bringing back to the board a recommendation for the 3 hospitals in Monterey for consideration, and consider that we move the other sectoral definitions piecemeal as we're able to digest them.
Elizabeth?
Yeah, similarly, we clearly have a lot to do, and this is going to take some time, so I'd love to get started as soon as possible, and I support starting with Monterey. I have a question also. So what about sort of the administrative entities that we know contribute to cost? Like, is a qualified entity for this like a PBM or a health plan, or, I mean, I assume they also would fall under a sector, or no?
For a PBM, so PBMs aren't expressly defined as a healthcare entity in the statute. They can be considered under the payer definition, but it's we'd have to kind of explore that further in terms of like what exactly we would be holding them accountable for, because our statute is focused on spending growth. And for the other question you had about payers, their administrative costs and profits, is that right?
Right, or you read about the multi-plans of the world who are certainly contributing to cost with questionable value. So where do they fall in this, if at all?
A plan could be its own sector if we wanted to focus on for example, small group plans or individual market plans. So sector could be, a plan. Payer categories could fall into that.
Okay, thank you.
But OCA is also will be reporting on administrative costs and profits for plans as part of the total healthcare spending reporting.
Dr. Pants.
In addition to, in terms of first steps, I'd also put out there. I mean, we've discussed this, but the geographic sectors, right? We've talked about it. You have your slide. I haven't heard significant objections to looking at doing that geographic divide, but I do think that given back to the diversity of the state economically and so forth, I think it makes sense to at least go ahead and move forward on establishing a geographic set of, start defining those geographies, and then of course obviously the sector targets come after that. But I think it's going to be important to, I would suggest perhaps putting forward a proposal related to the geographic sectors.
Okay, so yeah, Michelle, I think at least to get us started on the hospital sector, starting in Monterey seems like a good place to start because it gives you the opportunity to think about the methodology we're going to use for hospitals. And then whether we go to other regions based on testimony or data or the like, but that would be a good place to start.
Thank you.
Don?
One other consideration, I kind of said this, but I want to say it more explicitly. I think part of what matters here is just the impact on statewide costs. So, as I try to differentiate Alpine County, and I actually shouldn't use Alpine County, a small county in the northern part of the state, and Monterey, It's that Monterey's costs are crushing us, and we don't have very many people in Alpine County because not very many people live in Alpine County. We need to fix the problems across the state, but they have different magnitude of consequences. So as we think about sectors and an action plan, I would encourage us to look at places where a lot of people live. So, you know, the Bay Area, parts of the Bay Area are probably very high on the list for needing to take a special look at. And I just, that's just kind of pragmatic and can't think of why that would be a bad idea.
Super helpful, Doc. Super helpful. Okay, there's no other comments from the board. We will take public comment on this item, please.
We'll now take public comment. If you're attending virtually, please raise your hand. If you're in the room, please step to the podium. Seeing no virtual hands, we'll go to the podium.
Beth Capel, Health Access. As I mentioned, we've written to you 3 times about sector targets, so obviously it's on our mind. We would encourage that we begin with Monterey and begin with a lower target. The lowest target that you can do under the law would be 0.1% or in that range for those 3 hospitals, which we think the data makes clear are in fact outliers. We would then encourage using the HPD data rather than private data sources, that you look at, that the staff look at the top 10 or 20% of the high cost outliers. We would suggest starting with hospitals. For commercial coverage, we pulled a number of rate filings. For commercial coverage, they are 40 to 50% of the cost. And so that's kind of a big chunk of the cost. They are inpatient and outpatient hospital costs are the biggest part. Your earlier statistic of 38% was looking at all healthcare spending, including long-term care. That's not such an issue with the under 65 population, thank goodness. So we would encourage you to start by looking at the top 10 or 20% of the high cost outliers. And for those of you who live in the Bay Area, when you drive back home today along Interstate 80 as you drive through Fairfield, know that you're driving past one of the highest cost hospitals in the state of California. It is correct that Monterey is an outlier. There are lots of others. We have looked at the RAND data arrayed by percent of Medicare, and there's a lot of stuff we could do to move the needle in terms of cost and premium statewide. We will also encourage you to look at physician organizations and to not limit your discussion. We have 2 different sets of data on physicians, one of which suggests
2 minutes.
Very useful studies by the Congressional Budget Office summarizing the literature that physician compensation is closer to Medicare than hospitals are, but that's not always true. The literature we reviewed on surprise medical bills found that anesthesiologists got charged 900 to 1,000% of Medicare, which seems like rather an outlier to us. So we think there's a lot of opportunity here to improve things, and we encourage moving to sector targets. One final point, we have supported the use of the Covered California data. The work on Monterey, where we had a monopoly and a duopoly between the 3 hospitals, suggests to us that some more fine-grained analysis may emerge from looking at high-cost outliers. Thank you.
Thank you. Looking virtually, seeing no hands raised, going back to the podium.
Hi, I'm Regina Chagoya, representing CFT, a union of educators and classified professionals. Regarding the board's statutory authority to address high costs, we ask that the board take into consideration and subsequent action on targeting graphic regions and individual entities, such as hospitals, and move up the timeline for implementation. as soon as possible, along setting the annual total health care expenditure annual increases to as little as 0.01%. Our members who have suffered economic abuse in regions that have bad actors, like the Mortgage Health Community Hospital Monterey Peninsula, they should not enjoy the annual cap of 3.53% per year after enjoying decades of pillaging the commercial insurance payers of that region without any regard to the economic harm they've caused folks. Enough is enough. Thank you.
Looking virtually, seeing no hands raised, going back to the podium.
Yevna Grajchinovich with Unite Here Health. I think it's important for you to understand the power, the signal that you send by your actions. The attention on Monterey and the fact that you went to Monterey had already a significant impact. That $50 million that CHOMP pledged would not have happened without the work that you have shown and the attention that you have paid to this issue. It's not enough, but it's a start. CHOMP has also reached out to Unite Here Health to offer some additional discounts, which they also offer to another large employer in the area that they mentioned in their letter. Again, it's significant. It's not enough, but it's a start. This is the time to continue to put your foot on the gas pedal. Board member Kronik, talked about whether it's defensible to be responsive to all of the stories. Is that enough? And I guess I would, have you think about what does it mean if you aren't responsive to all the stories of all the people who have taken time off work, who have spent hours driving here from Monterey. And so I understand you're in a difficult position and there's a lot to balance, but I really hope that you can not wait until 2028. We need the relief now in Monterey. So thank you for your continued work on this issue.
Thank you. Looking back virtually, seeing no hands raised. Looking to the podium. We'll give it a moment. All right, that concludes public comment on this item.
If there are any general public comments, we'll take those now.
All right, requesting general public comment. Seeing no one stepping to the podium, seeing no hands raised virtually, we'll give it a moment. That concludes public comment.
Great. That concludes our meeting today. Again, welcome to you, Secretary. Delighted to have you, and we stand adjourned. Thank you.